So welcome colleagues, both in the East Ham Town Hall chamber and those that are joining us via Zoom for this blended on Zoom and in-person session of the Health and Wellbeing Board here in the London Borough of Newham. Myself and my co-chair colleague, Dr. Mohammed Naqvi, will be sharing the chairpersonship of tonight's meeting, and I will be covering off agenda items 1 to 5 with Dr. Naqvi covering off chairing from agenda item 6 to 12. And I trust everyone that's present for today's meeting in terms of members have had a restful, albeit no doubt busy, summer holiday and break, and have been enjoying the weather over recent days, but also the past couple of months. We're going to be jumping straight into the agenda. Before I do, can I just ask that colleagues that are in this meeting in person, if you wish to raise a question, if you could just raise your hand for the benefit of those colleagues of ours that are on Zoom so that they can note. And those colleagues on Zoom, if you could just use your virtual hand function on the Zoom functionality platform, that will be really helpful so that we can keep track. And obviously, this is a meeting in public. And if you do want to ask a question or respond to a presentation, please just state your name. And so if you are presenting on an agenda item, if you could clearly state your name and where you are from, so that members of the public and press that may be watching today's live session know who you all are. So I firstly want to take any formal apologies for absence that have been received by the clerk to the committee. So could I kindly be advised so that we can formally note?
Yes, Chair, we've had a number. Sarah Ruins and Adam Sewell of the New Hospital. Also an apology from Althea Roderick, who wasn't able to speak here today, with clash of other engagements. Just a couple of other pieces of information, Chair, if I may. Paul Ellis is joining us virtually today, but he will be part of the meeting. Because Dr. Andrew Kelso is sitting in for him, and I think that's everything from me so far.
Brilliant, thank you very much. Right, so colleagues, just also want to draw your attention to the declarations of interest statement as set out in the agenda pack across pages 5 to 8. And I need to formally ask if there are any declarations of interest pertaining to matters that we're going to be discussing tonight that any members of the Health and Wellbeing Board here at Newham need to declare. Are there any declarations of interest? No? No. Okay, thank you very much. And then I'm just going to draw everyone's attention to the minutes of the last meeting of the Health and Wellbeing Board that took place on the 9th of June. Can I just see an acceptance that these are an accurate record or correct record of the proceedings that evening? Is everyone agreeable to that?
Chair, if I may, I have some information, some qualifying information.
Okay.
That would be acceptable to you.
Yeah, of course.
I was delayed in preparing them, and at this stage, there is a draft set which has been reviewed by Colin as Director for Adults and Health. But I haven't circulated them wider at this point, but with your permission, both yourself and co-chair Dr. Naqvi have seen them as a preliminary measure. But with your permission, I'd like them to be deferred so that other members can actually have an opportunity to view them and sort of read them comfortably.
Of course. Are you happy with that, Wax? And apologies, colleagues. So we'll be deferring the minutes of the 9th of June 2021 meeting to the next meeting of this board to give you all time to review and consider and confirm their accuracy at the next meeting. So now we're going to be going to the COVID-19 update, and I will be inviting relevant colleagues to introduce, albeit I just wanted to check who's leading on agenda item 4A, cases, trends and trajectory, including testing rates.
I'll start with that.
Yep, okay.
And then other colleagues, I'm sure, will come in.
Yep.
Okay, so the current situation with COVID-19 locally is that we have a relatively stable position. The rates bob kind of up and down from 150 per 100,000 to 250 roughly in that over quite a number of weeks have been bobbling up and down in that space. That's for quite some time. They're currently coming down a bit, but with rates, for example, in Scotland having increased significantly since schools returned there 2 weeks before England, and we might anticipate rates going up again. And we've had those, not insignificant rates for some time now. I think what's really, and testing has remained very high. So the community are using tests, using both the PCR and lateral flow tests. So the testing rate has remained high, so that's good. So we think we continue to identify a decent amount of COVID in the community. Just to give a bit of perspective on what those numbers mean, that's roughly somewhere between kind of 60 and 120 cases notified per day of positive confirmed cases. What's really striking is, and the positive side of it, is, those cases are clustered amongst younger people who are the least likely to suffer from the worst COVID outcomes, notwithstanding all of everything we know about long COVID, for example. And so despite a kind of an ongoing reasonably high rate of COVID, the mortality rate locally has dropped significantly. Although we do still see, on average, a death of a new resident from COVID-19 every 2 days. So it's, remains a kind of significant impact on our community. And I don't know, Andrew might want to comment around that, kind of the people being admitted and vaccination. I know that Bart's have been doing some work on that. I'll pause there and let maybe John come in on the vaccine rollout.
Vaccine rollout. So we have new cohorts upon us. So we are particularly now looking at our 16 and 17-year-olds and encouraging as many of them to come forward for the vaccination, recognising a number of those are in educational settings. So we are not only inviting them summer months when they became eligible for the vaccine to come to our multiple vaccine sites, but now thinking about how do we support them in their place of education through outreach as well. In addition to that, we are also seeking to identify and encourage all those who are clinically vulnerable in the ages of 12 to 15. Alongside that, we recognise that the Joint Committee on Vaccination and Immunisations recommended for the general population aged 12 to 15 that they wouldn't promote that as being an eligible cohort. But we know that that's now been referred to the chief medical officers of the 4 home nations of the UK to review that from a wider perspective, a wider societal perspective, impact on education, development and other factors. So we are preparing for, should that be announced, probably in the next few days, the ability to be able to invite those people to come forward to their vaccination. We are currently at about 60% of our first vaccinations completed for the borough, which is positive, albeit as we grow with the number of eligible people, our denominator rises. So that feels a little static and a little low, but we recognise we've invited a whole new group of people to come forward. So the work to support people to get their first and second doses remains a very high priority for the borough and for the partnership to get as many people double vaccinated as possible. We want to use the opportunities that people will have from October, particularly attend large events, as a catalyst to try and get particularly our younger groups where, because they've been eligible for the least amount of time, get as many of those to come forward for their vaccination, associated with the incentive of being able to go to such events with their vaccine passport. So our work on inequalities and uptake continues, and we're still contacting residents on a regular basis. So this week we've invited, again, all 16 to 49-year-olds to come forward to their vaccination, as we recognise, as we plan for our booster coming from the 20th of September, we want to get first and second doses as achieved as much as possible. The booster campaign is going to be done in 2 phases based on risk and based on age, which is about 125,000 people in the borough of Newham that we will be inviting through an expanded suite of sites. So we have more GP practice sites for our primary care networks, and we have more community pharmacies delivering. So we want to make that as accessible as possible. And we're beginning to invite people to come forward for their booster from the 20th of September, as well as keeping open the option for as long as possible for those people who have not had their first or second doses who are eligible to. So that remains both an evergreen offer for those people to come forward, plus then trying to get the 3rd dose or booster for all those people who have had their 2 vaccinations to date.
And I'll just add to that, I do think it's what I'd like to put on record that 60% equates to nearly 220,000 people in the borough having received the first dose of the vaccine, which, albeit we're really continue to work hard to increase that number, is a pretty remarkable effort by the NHS, local authority, community and voluntary and faith partners, and really the whole borough. That's, it's a huge, huge number given just the sheer scale added to what we know about the barriers of access, of trust that we know there are in the community. So lots more work to do, but I think, compared to anything public health historically, a pretty remarkable achievement as well.
Thank you very much. I'm just going to be opening up to any questions on the back of what you've heard. Councillor Zulfikar Ali and then Wax.
Thank you, Chair. Thank you for collective update. Just a few questions, really. First, if I start with the positive cases that come up through, is there any indication of what percentage of those are those who had the first or second vaccination? And similarly, those who are hospitalized, is there indication that those who are coming into hospital, what percentage of those are actually vaccinated or not? And then I'll come back to the other question on the 16 to 18, if that's okay.
So that we don't actually have that data for cases, but we do have some data from the hospital. I'll let Andrew come in on that because I think it's quite powerful.
Yeah, I mean, certainly for intensive care, every single person that's gone to intensive care with COVID has either been unvaccinated or immunosuppressed for another reason, and therefore likely to have a good response. And a high proportion of patients, I couldn't give you a percentage, but a high proportion of admissions are unwell or unvaccinated, don't make ICU as well. There's a small number of vaccinated patients that are admitted to hospital, but they tend to short stay and recover quickly.
And what's the age range, roughly?
It's a younger range of patients. We've seen far fewer older patients admitted to hospital.
Great, lovely, thank you. In terms of John,
as well.
Sorry.
Lower mortality as well.
Lower mortality, yes. Thank you. In terms of booster, John, you mentioned we're starting in September. Do we have any idea what is the number, the volume of cases in those vulnerable categories? I know that we don't know yet what the exact criteria is, but is there any indication what sort of numbers we're talking about? And can you also give us some assurance that GP will play a part, unlike what they did in the initial phases of vaccination, that they will be giving people these jabs?
Yeah, so the first stage is about 50,000 people, and that's care home residents, people over the age of 70, frontline health and social care workers, clinically extremely vulnerable adults. And then stage 2 of the booster is all adults age over 50, and those who are eligible for the flu vaccine, so adults aged between 16 and 40 who are at risk as well as those who are immunosuppressed too. And that's about 75,000 individuals. So 125,000 in total, as far as we know, will be eligible for that booster. There may be further waves of the booster for other cohorts beyond that. We don't yet know. We'll of course react and plan to that. And we also recognise that at the same time as this, throughout the next few months, we'll also be doing flu vaccinations as well, which is important. In terms of who will be delivering it, have new primary care sites coming on stream. They're going through an authorisation process. So general practices, they've been authorised and have had lots of equipment ready for them to deliver vaccinations in local communities, and they'll be responsible for calling in patients. For example, one practice may take the lead and provide a site on behalf of a group of them, and they'll be responsible for calling those patients in and getting their vaccinations done on behalf of a group of practices, as well as trying to encourage those people who have yet to have first and second dose to come forward as well. So that gives us new capacity. And we're also bringing online new pharmacies as well. We don't yet quite know how many, because they're going through the assurance process, but we think it's going to be around half a dozen minimum, which again gives us more access and capacity in the community. And again, we'll be working to make sure that we invite as many people, increasingly for those who are more hesitant or concerned about the vaccine, conversations with their local practice opportunistically, with more local primary care-led sites, GP-led sites, I think will help us get the uptake higher, particularly for our under 50s group, where we need to do more to encourage them to get their vaccine.
If I may come back to that is positive to hear, John, but the fact that only 3 practices took part in the initial vaccination, and you now said that they've been given the tools and they've been authorized to do vaccination. What I would like to know is where is going to be that oversight or governance? Who will produce the data? And secondly, are we in a position to actually split the 75 or 50,000 people that you have along the PCN line, so we know exactly which PCN has how many, and then we can monitor and get a report back to this forum in due course?
Yeah, absolutely. So to answer the last bit first, those primary care network sites will be setting up. They will be given vaccine appropriate to the size of population they need to vaccinate. And that is those people unvaccinated from their first or second dose, as well as those requiring a booster. So we'll be quite clear that they will have the infrastructure and the vaccine to be able to deliver those numbers. And we'll be monitoring those and supporting them to get as many of those people vaccinated as possible. So we will have the oversight from the volume going through. I think the first comment related to how primary care established its sites for the earlier phases of the programme. So the practices in Newham came together and decided to establish 2 main primary care sites, both at Sir Ludwig Gutmann and at Essex Lodge, as main delivery sites on behalf of the borough. They were, of course, complemented with other mass vaccination sites and outreach sites across the borough as well. What we learned from that was we needed to do more. So as the programme grew, we then started regular vaccination sites, from primary care outreaching into next door in East Ham Leisure Centre, and then at Wood Grange Surgery as well, running regular clinics. So I think we would have ideally have had more primary care sites come forward in that phase. I think having 2 at the start was probably not enough, and I think we've learned from that. However, I think it's worth saying that this is an optional thing for practices in line with a national commissioning framework, and that's what the practices locally chose to do. And what I'm pleased about is we've learned from that, and now we've got more sites being established as the volumes get higher and we start the booster campaign.
I take what your consideration in that regard, but I frankly feel that GPs have a central role in the health of their patients, and for them to choose this as an option not to participate is absolutely ridiculous. And secondly, I know you said that we set up Essex Lodge and others. Is there any evidence to demonstrate which GP, what GP proportions were actually referred to those sites? Because I believe that people went there because of publicity the council has provided, our partners, the health champions, but it'd be good to see whether there is any evidence to support that GPs have actually referred people to Essex Lodge or to the other sites. I would really like to see that, if there is a possibility of that.
Yeah, so I think I'm just trying to think if the data is possible. What we have done throughout the process is use a single system for inviting patients called AccuraX, which has invited people as they become eligible. And what we've tried to do with that is to say, you don't necessarily just have to go to Essex Lodge as one site or SLG as the other. There are other options, and that's why we established a call centre to help people find the most convenient for them. But we do know at what volumes were called, at what time, and I think we've got data which shows that those calls over the past year. I think the point you're getting at is variation in proactivity from different practices, and I think that's fair. And I think part of that relates to workforce. It relates to workload. And I think we saw differential inputs for a multitude of reasons. I think now, as we enter this booster campaign, there is a more coordinated response now from local practices through greater sites. I think that's part of the learning that we've gone through.
Thank you. I'll be very brief, Chair. I think it'd be good to get a report at the Future Health Wellbeing Board on the success of that latest initiative. My last question really is about the 16 to 17. And you said we're going to have more pop-in clinics, etc. And we're going to be working with schools. What is the communication plan in that regard? And secondly, are we intending to have pop-in sort of, mobile sites within schools in order to encourage or facilitate those so that people, when they are in exit school, they actually benefit from the jabs rather than having to go to sites?
Yeah, so I think the initial response, because the decision about the eligibility came on us really quickly. So I think it was about the 4th of August. So we wanted to quickly say, if you can make it to one of our centres, come. So we invited all approximately 9,000 people straight away, and we've invited them subsequently as well. I think to date we vaccinated about 2,500 of the 9,000, which is good, particularly in the summer period. So now I think through a range of different partners, whether that's children's services in the council, whether that's health children's services, education, is now working out where do we want to deploy these sites and who's going to do it. We have commissioned a roving team of vaccinators who are able to go up and set up at short notice. So the plan is coming together exactly on how that's going to work. And I think there'll be then communication through the school to the parents, because for that particular cohort, they could consent for themselves. We've got a slightly different challenge for the under 16s, where we need to get parental consent and encourage parents to sign up for it as well. So that's also being looked at for those who are clinically vulnerable, and potentially for all 12 to 15-year-olds if they become eligible.
Thank you, John. Thank you.
All right. Wax.
Councillor Valley's points are well made. The demographic of the borough really shapes the rollout. I don't know if you recall, December the 15th, our eligible population was around 4,000 to 5,000. And vaccine was delivered in lots of around 1,200. So having sites with that few number in that cohort was not practical and potentially would have been wasteful. Very quickly having the second site to back up our first site in Stratford was the approach that was taken, and a sensible approach. Vaccine flows, the rate of delivery increased, and the sites, unfortunately, despite us trying on numerous occasions, we were never able to increase the numbers of sites, and that's not what we wanted to try. And Jason and John know that.
I think the point I was trying to make was, if the GP studies are available in order to be those pop-in centres, then clearly that will have had some impact if GP did call people.
Yeah. So the call.
I know you tried your best, and you.
No. The call recalls. There's no. The call recall situation that, as John's explained, is various. But in terms of practicality of the rollout, that really does depend on the demographic, and we weren't going to be wasting or cracking open a box of Pfizer and then not being able to use it, knowing full well that Newham Hospital site and our Unbarred sites and our sites were also delivering Pfizer vaccine, which we didn't want to waste in the borough as well. So that was more about the rollout. Now, that said, booster program, I do think there is an issue. Our demographic eligible population, 240,000 residents eligible for vaccination in the last 3 months of phase 1 and phase 2. That means I do think we'll have a pretty large eligible population towards the end of the phase 3 program as well. And actually, you know, what I think the push from us really is that, you know, we want to vaccinate people as soon as possible, but our hands are tied in terms of, you know, who we can vaccinate and when we're allowed to vaccinate, and that's not in our hands. Now, opportunities will come, and we need to make the case, I think, to be able to drop those cohorts as soon as they're announced and we're allowed to do that. That would be one of my biggest learning points from that first program, our demographic. The majority of our, so out of that 350,000, you know, first doses that we've done, 240,000 of those were not eligible for vaccine until the last 2 or 3 months. And actually, 180,000 weren't eligible in the last sort of 6 weeks. So, you know, I think we've done a fabulous job. We're a couple of % of uptake off our neighbouring boroughs, and we know North East London, the uptake has been very, very difficult. Yeah. We need to understand why that has been. And myself and Jason in a meeting earlier today that, you know, we want to understand more about, you know, that 40%, 39% that haven't taken up the vaccine as to why. But I think we need to go away and actually push the powers of be to give us the freedom to flex our delivery demographic, because I think that would be important, because we don't want this program going on and on and on and on. Andrew's made the clear case that those are vaccinated, those are unvaccinated are ending up in hospital. And with the cases the way that they are, people moving around the way that they are, I don't think that that's going to change. So we do need to keep on vaccinating. That evergreen offer is super important, and we do need to booster dose those who were vaccinated early on in the year 2021, and make sure that they're protected to the level that they need to be, based on what we're seeing with the data on the AZ and the Pfizer vaccine.
And the flex point has been a point consistently made from the time we were notified that the vaccination programme will commence. That was back in December 2020 when we had the meeting with Sir David Sloman. We said we know our communities best. We know that they need to be very much located at hyperlocal level. But the point that you've made around, you know, the coming forward of the GP practices is one well made, notwithstanding the practical issues around rollout and how that was specific to particular age cohorts in the first instance, and just given our demographics here in Newham, that left a significant number of the younger age cohorts right to the end, and we had to scrabble to try to sort of advance on that. I've got Councillor Aisha Chowdhury, and then I've also had an indication from Colin that you wanted to ask a question. Councillor Chowdhury.
Thank you very much indeed. So some of my question has already been answered. Thank you for that. And because of my network problem, if I have missed and asking for something to be repeated, my apologies in advance. So I am trying to understand that people who have already had their second doses, do they still go for booster or not? In addition, if I can just ask a few other small points, they're not big. What's the difference between booster and vaccinations? And in addition to that, with some vaccinations, you can go abroad, with another you cannot in certain countries. Once you have your boosters, would it be the same or different? And yeah, especially when you are going abroad, is it going to be okay? Thank you.
So absolutely. So it's worth thinking about the booster as just a third shot. It's just the next stage of the vaccination programme. The effect is to boost the immunity, but it's a third jab. So that's what people are being encouraged to do, who fit those categories, is to have 3 jabs. But as discussed, we're still waiting the final guidance on that before that starts to fully roll out to the much larger population who we think ultimately it will go to. As to the impact on travel, that's I don't think it will have any particular impact, but I mean that will be about kind of national policy decision making, not anything that we do at a local level.
Okay. Is that okay, Councillor
Yeah,
Chowdhury?
thank you very much. Thank you.
All right, super. Colin.
Thank you, Chair. So my question is really back to the 125,000 cohort, and obviously that decision has been made for a reason in terms of risk profile. And I suppose from a health and wellbeing point of view, what I would be interested to understand is, of that 125,000, how many of those have already received a double vaccination, so that we can understand the level of risk, potentially exposure, that we have as we go into the autumn and winter months for those individuals. So maybe not an answer right now, John, but maybe as part of the we could identify that, because I think that from an assurance point of view, from a health and wellbeing board point of view, is the kind of thing that I'd need to understand to say, well, what's the level of exposure in the borough should this cohort continue to not be vaccinated?
Yeah, and I think the first group is easier to answer because they were the earlier group. Those over 70 health and care workers, extremely vulnerable. So we're at about 80% roughly of that cohort who have been had both vaccinations. The second one is harder to answer. Particularly younger years, age 16 to 39, who have some clinical vulnerabilities and may be eligible for a flu vaccine, but may not have exactly matched other cohorts, so they may have been the last to be invited in some cases. So we need to make sure we are clear about which of those have been vaccinated for both doses or not, and then make sure, ideally, they get their first 2 vaccinations before we invite them for a booster, because we want to give them their first dose as a booster.
Okay.
Thanks,
Is that okay?
Yeah, thank you. Thank you, John.
I've just got a couple of quick questions. I can't see any other hands up on the Zoom of other members of the board wanting to ask a question on this matter. And I know that we've got to cover off social care.
Yep.
And acute update, albeit we had some information which was quite alarming. So a couple of quick questions from me. So in relation to the booster campaign, and noted that it's going to be rolled out into phases based on age and risk, and there's in total 125 eligible. How many of the 125 eligible for priority booster occupy the age risk profile as it pertains to those with disabilities as well? Because that's an issue. And how does that compare with the picture and position of those with extreme clinical vulnerabilities, but also have disabilities? With regards to first jab and second jab, and what is being done to address that and remedy what I understand to be pretty low numbers. And then in the lower age cohort of that section of our community, resident community, i.e. 16 to 24, who have either special education disability needs, and it may be very challenging for families to get them to places to get vaccinated. What's been done across that? Has there been quite a lot of deep analysis and remedial work underway to address those issues?
Yeah, so just to answer the last bit first, again, there's a formed around our community team that look after children with particular illnesses and disabilities, from ELFT and from BARTS and from team in public health, as well as children's services, because this group of children are well known to services, and through that route we think is the best way of contacting them and encouraging them and their parents to consent to the vaccine. So that's been done very much on a case-by-case basis. I think for broader understanding of people's ability to access the vaccine, we continue to offer a service for those people housebound. We'll be offering vaccinations in care homes, places where people, residential care settings as well, as appropriate, and continue then to offer outreach. We have established now a roving team that responds to very particular circumstances that people have, so that we can respond very much on a personalised level to those people. We recognise that that's the difference between them having the vaccine or not. Then offering that support is essential, and very much not expecting people to roll up in a uniform way to a big centre, because we learned very quickly from the national policy that certainly didn't work across the country, and didn't work in Newham particularly.
Okay, thank you very much for that. Also, you said in your initial update that there were more GP practices that have signed up to the booster campaigns, and I didn't catch the quantum number of additional GP practices that have joined. So I understand that it was previously 3 for the first and second. So what would be the position now?
So I think we've got a further 4 sites. Is that right? 4, yeah, 4 now.
There was 1 initially. Then into phase 1 there was 2, and we've gone to 6 now. So okay. 4 new sites.
And then again, picking up on Councillor Zulfikar Ali's point, what more is it that we need to be doing, given the locus of GP practices in the broader health space, and enabling us to address the issues of health inequality, to encourage them, but also, more importantly, for us as an administration, where we are anchoring our recovery strategy on the health and wellbeing and happiness of our residents, alongside addressing long-standing systemic issues of health inequity, to hold them to account. So who is it that needs to be invited to the next meeting of this board to advise us what the impediments are, so that we can work to overcome them? Is it a monetary financial incentive? Is it just I can't believe a GP practice operating in Newham, motivated by, a moral response to keep a population at large healthy, do not want to do vaccines because they can't be asked? Forgive my language.
So if we just look at flu vaccinations for a second, so the flu vaccination is done by pretty much every practice each year, and they will call and recall their at-risk groups and get them vaccinated. Now, there's variation in how many people they get through, which is a constant challenge for us to try and encourage people to do. Originally, I think we all anticipated that that's how the COVID vaccine would work. We have to remember there was an environment where general practices were told, from a national policy perspective, you need to recover and restore your core services, and we will establish mass vaccination sites that will take care of these things. And there was talk of those vaccination centres being 24/7, drive up, drive through, and so on. So there was a period of active discouragement of general practice to participate in it. So I think we've got to look at COVID-19 vaccination slightly differently from other vaccinations. However, the broader point is, how do we drive accountability for public money that goes into our primary care services? How do we reduce variation? I think there's a very good opportunity for us to do that. I think it's got to be a core part of how we address and approach groups of practices working together now as primary care networks, because their first role is to improve the care they collectively provide and challenge one another to do that. And I hope that's a better vehicle. In terms of who's accountable for commissioning them, in many cases that's NHS England, who provides a national framework and invites them to participate in it. And again, a lot of it is voluntary from that perspective. they can participate in additional aspects to their contract or not. What we try and do is encourage them, our practices, to do that, and I think the primary care networks will help with some of that. The things that we choose to commission locally and organise locally, I think there's accountability through a primary care contracting function that sits within the NEL clinical commissioning group that has that responsibility. And from April, that will remain in place but be transferred, subject to legislation, to the integrated care system in North East London. So that will remain, and that those individuals are able to come and represent here about their plans for the accountability, performance management and improvement of general practice. But also I think there's something about how do these new primary care networks take greater responsibility for the quality of care and the outcomes they're achieving with their population, and what support do we give them to do that?
Okay, so can we invite someone to the next meeting, but it will be from the NEL?
Chair, once we welcome the 4 additional sites, I mean, there are 9 PCNs and 9 PCN directors, and they're all accountable to the primary care commissioning team. And I suggest we invite Jenny or what's his name?
William.
As well as clinical directors, if frankly, to tell us what they're doing and what their response is.
Okay. Can we capture that as an action, please?
Yes.
Thank you. I've got one other question, but I saw your hand go up. Did you conclude on your point? Oh, okay. Okay, thank you very much for that. And then my final question, or rather comment. So as we enter into this booster campaign from the 20th of September, obviously there's a lot of preparatory work underway and the communications. Doesn't that provide us a additional opportunity to re-socialise and raise awareness about the importance of vaccines amongst the wider population, not least because of what you said earlier, where some of the 40 people admitted in the time frame that you were referencing to hospital, most are coming to hospital from that younger age cohort who haven't been vaccinated, and some of the ICU. So I think that period in the run-ups and thereafter, as we're promoting the double jab, is also an opportunity for us to reignite interest amongst that age cohort. And I'm assuming the reluctance of that age cohort is understood on the basis of research that's been undertaken over recent months as to why they're reluctant. It's just hesitancy because of, I don't know, concerns about the vaccination, its efficacy, its dangers or purported dangers, or being persuaded by the anti-vaccination voice.
Or for many, just low priority because they don't perceive that they are terribly at risk of becoming unwell. So it's a mixture of factors.
Okay.
But yes, absolutely. We will, on the outreach and the campaigning, we will. I think it's a massive opportunity, and we will need to do a lot to reach our numbers for the 3rd booster dose.
Yeah. Okay. Oh, sorry, Wax.
And just a point of clarification: the PCNs are accountable to patients, but NHS England, not the CCG. And so we'll pick up some of this when we invite William. But the primary care directorate across Town Hamlets, Waltham Forest, along with the other NEL boroughs, embarked on a programme which has been running now for 3 months. Action those inequalities, those differences that that we have seen, along with a differential in funding that there is across the boroughs, and I've shared some information with you, but we'll ask William to present that, and I think that'll be really useful.
Is there anyone in addition to William that should be invited to come?
Can I see, Claire, I know what you said, Max, but who appointed 9 PCN directors? Is not CCG, Primary Care Network, or NHS England appointed?
It was the practices.
Sorry?
It was the practices.
Ultimately, someone must have had some governance arrangement in terms of who appointed them.
So my understanding is, with the 10 that went down to the 9, it was a different process. Each the process was for each of the PCNs was approved by the LMC and NHS England, and oversaw that.
So CCG does have some degree of accountability. Primary Care Network Committee does have some clout at least.
Well, I'd say it's more of a reporting function back to NHS.
So NHS England are the ones, right? Okay, yeah. And there's no one else except for William is the right person.
I think William.
Okay, cool. Let's move on. Is there anything else on the queue update that you wanted to add?
I talk for hours on
Yeah, please. Yeah.
Just an update on, we're going to talk about elective recovery later, so I won't talk about that. We're making good progress there. But some of you will be aware from other routes, we are extremely busy at the moment. As an example, yesterday we had 450 attendances in our emergency department. So almost 250 what's called type 1 attendances, which are the patients that have to be in ED. But 204 patients in the type 3 attendance category, which are patients with minor injuries or with minor ailments that could be managed elsewhere, and they go to our urgent treatment centre. And as a result of that, really by sheer numbers, but also because the hospital is fairly crowded, only 67% of our patients were treated within the 4-hour target. We're aiming for 95, so we're not getting where we need to be. And that's not isolated to Newham Hospital. In fact, that's not even isolated to North East London, it's a national picture. We've currently got 14 patients in our intensive care unit with one spare bed, but that's because we're exporting patients to other intensive care units across North East London. So we're acquiring mutual aid to manage our intensive care demand. And our paediatric ward is currently full with a combination of mental health issues, but also physical issues in children. We do have general staff shortages, which is a combination of sickness and vacancies, but we are noticing significant sickness, which we think is coming out of difficult 18 months and burnout in our staff. We're currently caring for 9 patients on the ward requiring extra respiratory support over and above oxygen. We call these patients NIV patients, and that's an indication again of the general acuity of the hospital. We'd normally expect to have up to 4 of those patients in the winter, so to have 9 patients in September is well, it's not remarkable, but it tells us where we are. And we've currently got between 30 and 40 patients with coronavirus in the hospital. We have been up to 50, but that's slumped a bit recently, so we're seeing that fluctuate. And I just wanted to give you another update because you might be interested personally. You remember that you came to our safety listening event a few months ago. We've managed to make some, I think, fairly significant changes to our safety profile as a result of that. We had that event to listen to our staff in relation to concerns regarding their own safety after the murder of Sarah Everard and the sort of publicity around that. As a result of that, we've started self-defence classes for our staff. We've also had a full security and lighting review of the hospital and the hospital site, which has given us some improvements. And as it gets darker at night, that'll be more important. But the most notable change is that last week we launched our shuttle bus service, which runs patients from the hospital to Plaistow Station and Canning Town Station between 5 o'clock and 11 o'clock at night. So hopefully that will have a good uptake and we can continue it. I mean, again, I could talk for a long time about other things, but I think that's the most salient points at the moment. To take any questions.
Brilliant. Well done on the shuttle service. Are they electric? I'm always asking for more. Don't worry, we'll get there. You're going to help contribute to meeting our 2030 and 2050 targets. Okay, any questions on the back of what we've heard wax and then sort of be?
I think I don't know what I think, but I think it'd be useful to invite the responsible commissioners if we are hearing about 4-hour waits, 60% being seen within 4 hours. It'd be useful to understand, what's happening around and to address some of those things from the classical kind of commission.
Okay.
Relevant to me. So is that Kelvin?
Yeah, I think there are plans underway because I think we look at our urgent care system and the access points are not easily understandable by the public and not easily understandable by professionals. And I think our concern is the rate of growth of the population and the choices people are making about where they access services makes us recognise that we've got to do something quite fundamental, I think, to how we manage the urgent treatment centre at the Newham Hospital site, but also think about the other services, the extended primary care services and others, so it's understandable and it's proportionate to the need we're seeing. And so a piece of work is underway now to particularly understand what the trends of population growth and those needs are. So I think we can reform a more sustainable and a better experience in our urgent care system. Because I think we've historically accumulated a bunch of different services which don't particularly respond to, I think, the requirements that the public have.
Yeah.
It's an important point, isn't it? Because we're not going to be blessed with having a bigger hospital or a new hospital site, and that site is stretched, the new site is stretched. So everything that we can do in terms of addressing the flow into the site and what we can do in terms of prevention and out of hospital is super, super important. It's looked after in that out of hospital space.
Yeah.
I mean, the very long-term outlook is that we might be able to do something, but it's not going to help us this winter. We've put in an outline bid for the phase 3 monies coming from NHS England for capital new hospitals work, which will include a new urgent treatment centre and ED departments at the east end, to work out the east end of the hospital.
Yeah.
We are planning, as a result of our fireworks, to build a new intensive care unit and another ward underneath it to really cater intensive care units, and that will also increase the capacity in the hospital. So there's a fairly big capital programme that we would like to embark on with reasonable indications that might be supported, but as yet, funds secured.
Okay, I'm going to come back to that on something to do with digital transformation and use of data to help enable the system to work better with each other and talk to each other. But Zulfi and then Colleen, I've also got Jason and I've seen Paul on the Zoom, so I'll take it in that order. I'm so sorry, everyone. Right.
Thank you, Chair. And it's helpful to hear the pressure that hospital is under in terms of A&E and not meeting the target. Clearly, that demonstrates that there are interrelationships between how effective 111 is and how effective GP system works. And I think if people are having to go through a very bureaucratic, lengthy process in order to get access to GP, and if they are frustrated and feel uncomfortable with their own health, then they will end up in A&E. Presumably, I would have thought a fair percentage of those 450 or so probably will fall into that category that they actually need to go to A&E. So I think the question is do we actually analyze the data that we have at A&E, and how is that communicated back through other channels to make sure that we can improve joint working relationship in order to reduce that pressure and also make 111 as well as GP practice more effective? I think the lack of face-to-face consultation is having a big impact, and that's probably the reason you're seeing a lot of people ending up in A&E because they can't see their GP.
Yeah, of course.
I don't disagree with anything you've said, and certainly lots of our patients tell us they've come to us because they want to see a doctor or a nurse face-to-face. What we don't know is whether they could have done that in primary care or elsewhere and they haven't tried for whatever reason. There is something about the product that we offer that patients seem to like as well, and we need to understand that better. And my personal opinion is there is primary care and then there's secondary care, and then there's something in between that patients want we don't quite yet understand. And that's the work that John's talking about to reconfigure that sort of emergency service that we've got. But I was reflecting earlier on the discussion about vaccinations and GP practices, and I was thinking, you know, if this were down to me, and thank goodness it's not, because I probably make terrible decisions if it was. I think there are certain things that only GPs can do, and a lot of that is the pressure in a hospital to be taken away by that. And actually, we can provide vaccines by another route, which can be done by people who aren't GPs. I'd rather use the resource for managing more complex patient needs if we had the opportunity. And I think our footfall is telling us there's a need there. My personal feeling is we should prioritise that.
Interesting. Anything else before I move to Colleen?
Thank you, Chair. I have a few questions. I do have a question from previous, which was in regards to the vaccinations. And maybe it's not an answer you can give now, but just in regards to that cohort of vulnerable children in the 12 to 15 age group, I just wondered if we have any facts and figures in regards to have all children in that age group been contacted for their COVID vaccine if they choose to have them, or the parents choose to have them, and if not, why not? I guess that's my question. I have a question for you, Andrew, which was in regards to, you spoke just a moment ago about staffing. And forgive me if I sound a little bit naive, but in my mind, a hospital cannot run if you don't have staff. And so in actual fact, for me, that was the most alarming thing you said, because I'm slightly concerned. No, actually, I'm very much concerned about understanding the impacts that COVID has had on your staff, and not just whether or not your staff are feeling burnt out, but actually, are they impacted by COVID in regards to maybe long COVID symptoms that they're suffering from, and what impact is that having on them and the hospital in a whole? I think is really important to understand. And my last question, comment, I guess, to a certain extent, the point that Zulfika made in regards to GPs. I think one of the biggest reasons why you end up with so many residents, people at the hospital in that category of, I think it was category C, you said, or something, that last category, it is because you can't get appointments. And what residents want is to see somebody. You can't get an appointment for love nor money. It's often 2, 3, 4 weeks away. And then also, apart from that, it's a telephone conversation. People are sick and tired of telephone conversations, and they don't feel like they're being heard as much as you may be listening. And also, you can only come with one problem, but you've waited 4 weeks. You know, you've got multiple problems. So I think there's a bigger issue there in regards to the capacity of the GPs, the waiting times of GPs, and the need to actually see somebody in the flesh. Because often those patients you talk about just need someone to see. They just need that reassurance that they're not going to die, or they didn't, you know, it's not in their mind, and they can go off and can continue. So they're just those 3 questions. Sorry.
I'll do them in reverse. It's for John, but I'll do the last one first. I totally agree. Patients want to see somebody, and one of the things we can sometimes do is make an appointment for a patient with their GP. They don't want that. They've got you now. They want to see you now because they've got somebody in front of them, and that's very resonant for us, and that what you say is very resonant. And even the fact that we can't see them again, that we can't follow them up, that we won't give them long-term care. We might only see them once ever. They don't mind that because they're seeing somebody face to face. And I think that message is coming through loud and clear. Whether that's the only factor or not, I don't know, but it's certainly a dominant one. I would agree. In terms of staffing shortages, I mean, a small number of our staff do have long COVID, and we are dealing with that as constructively and as sympathetic as we can, because it's something we all bear responsibility for. But actually, most of our staff shortages are due to general burnout and just general work overload. They've been working 110% for 18 months. And something has to give. And some of them have made career choices. Some of them have left healthcare either temporarily or permanently. Some of them have left their jobs. And some people are into health at the moment, particularly in the non-trained sector, because they see what's going on in health and they'd rather go and try their hand somewhere else.
Okay.
I mean, I agree, if you don't have staff, you don't have a health service. You're right, they're absolutely a more precious resource. We're doing a lot to preserve the health and well-being of our staff that we have, both with us, with dedicated health and well-being offer, including psychological support as well as general health support, but also in terms of career support, one-to-one meetings with every member of staff, enhancing our appraisal support, making sure the risk assessments are up to date, and really giving them sort of love and attention they need to keep them in work. Because often that's all it takes, is knowing that they're valued by the manager. And we know they're valued, but we have to show it better sometimes. So we're putting a lot of effort into that. The other thing we're noticing that's causing vacancies is the temporary staffing market has disappeared. So we would, in the past, fill 30–40% of our shifts that went to agency, and on some days we're filling less than 10%. And again, that is due to general willingness of people out there to either do extra work or to sign up for temporary work. And part of that may be because over the past 18 months, if you've been with an agency, you've been doing COVID one-to-one care, that's incredibly taxing and difficult, and staff are walking with their feet. So a complicated problem, but we're doing the best we can within our organisation to support the staff we've got to retain.
Brilliant. Thank you very much. Conscious of time. Jason, did you want to ask a question?
No, I'll save it.
Okay. Paul.
Thanks. Mine is just a very quick comment, but it's that if possible, I think the other group of people that we ought to keep a focus on is people in the community with long COVID, because that group of people, I think, is really growing, and we are starting to see how we're needing to work with them on an ongoing basis. And it does look like their needs are going to continue for some really quite significant time, and in many cases, really, really quite significant impacts on their health and their well-being overall.
Thank you very much, Paul. Any? Yep.
Can I answer the question about 12 to 15-year-olds with specific health conditions? So we've got good coding and good accurate understanding of those younger people with those conditions. So they're easier to find, and we're working through to make sure they're given the right information to hopefully come forward to have the vaccination. Where we don't have good data is on those 12 to 15-year-olds who live with someone who's immunosuppressed, because we don't capture that information routinely. So we're having to work hard then through those who are immunosuppressed to understand that they've got children living with them to then try and get the vaccine, so we have to cover it through another route. But on the whole, I think we understand the cohort well, and we'll have a very good proactive offer for them.
Okay, can I just come back? Sorry, John, and I don't mean to sound whatever the word is. Just in relation to those 12 to 15-year-olds that should have received by the 23rd of August a appointment invitation for a vaccine, have we done that here in Newham?
So for their booster, for the 12 to 15-year-olds, it's their first of their 2 doses. So that some of them will already been invited and have appointments booked. Some of them won't yet. But we will be inviting all of them imminently. Okay. One of the things we're having to do is to make sure that all the staff are trained appropriately with the right safeguarding training and the right resuscitation training for that younger cohort, to make sure that the service is safe to do that. So there's a period of making sure that each site is equipped to do that job.
So can I just ask, is there any chance that the data for that can come back to the next meeting in regards to all those young people that are in that cohort that should have?
Yes.
Yep. Okay, let's capture that as an action and then wax.
I was just going to say the current operating procedures are quite restricted. So we've got 6 sites, or more. We've got more sites than anybody else in London. But delivery to 12 to 15-year-olds is under a slightly more restrictive operating procedure for some of the reasons that John was articulating. And the numbers are in the low hundreds overall. So, for example, my practice, which is 16,000 patients, we have 8. They've all been invited, and 3 have their vaccines booked for the weekend.
Yeah. And just on a final point to conclude this, and I know we've got to get to social care and autumn-winter planning before we go to elective recovery update, and I'm so sorry in advance for my poor chairing, because an hour and 5 minutes. Right, but I'll be quick. Just you raised the really interesting point around how can we get the wider local system working better and choreographed and aligned so that we're picking up potential pressure points. What work's underway at the moment as part of the integrated care piece and transformation around using data and digital transformation to enable that? The reason I ask is because we're about to embark as a borough on launching our embracing of data, notwithstanding rightly concerns about trust and privacy and security issues around personalised data. And we want to be positioning Newham as an exemplar of data for the public good, which opens up and enables social value as well as economic value and impact for local residents. How advanced has it been in the context of the system locally, or is it still very much in its infancy?
So if I'll start and then I'll pass over to John. So in terms of the borough-based partnership, I think that John can probably talk about the thoughts around that and drive and the changes that Andrew was alluding to as part of that group. In terms of the data, we have been doing work in the past around this. So, for example, Zeus Care, which is the social care system, can access something called the Health Information Exchange, which allows us to see GP information, acute information, and vice versa. It works both ways. And I think we were one of the first boroughs to actually achieve that. But I think the access to it is one thing. The next stage is part of how we really utilise that data as part of understanding the cohorts and the things that we want to do and the interventions that we want to make, I think then falls within the work that we want to do as part of the borough-based partnership work.
As in informs occupational practice,
yes,
systems, agility.
Yep.
So is that an issue around appropriately understanding what the data is saying and then how that transposes into a reorganisation? So we talk about digital, but actually what we're talking here about is digital transformation in the way in which we operate and our processes and systems. Are we getting to that stage, or is that an area of work? Because I can suggest that it's a project, it's a priority project under Newham Sparks.
So I think the area where we need to build upon the good data sharing that's going on is the precision of our interventions. So how do we understand the triggers or risk factors better to intervene at the right time? So whether that's someone who's frail, who has an event that we then understand that because of that event, they're more likely to end up in hospital or long-term care, and we've got the ability to intervene but understand that better. So I think using that data proactively, I think is something that most developed countries are looking how to do pretty well, and in Newham we want to do that, particularly around groups at risk. The other thing that I think the vaccine programme has taught us is when we look at those people who don't attend for whatever reason, I imagine we've got very similar issues, cancer screening programmes and others. We want to look as much at people who aren't coming to services as those who are, and I think our curiosity around that, using data, I think will drive those people who we want to prioritise to be seen in our services in a more proactive way. So I think those are real priorities for how we not only combine the data, draw insights from them, particularly around forward-looking preventative events, and look at inequalities and uptake, inequalities and outcome from our population that we can then respond to in our services proactively.
Will it help address the challenge that Andrew's articulated, i.e. a movement of patients coming directly to A&E in the hospital in the first instance? Would it stop that?
Potentially not, because there are two problems in that. One is that they provide a very good service at Newham Hospital, which is great, and that's a choice and accessible to people. And we need to think about what services we locate there to meet that need. Just because we've traditionally had a smaller UTC there doesn't mean we necessarily would want to keep that the way it is. We might want to grow that to respond to it, or we might want to put alternatives in other parts of the borough. I think we've got to weigh up those options. I think understanding of people, why they're attending, and their choices, I think we should certainly use our data and intelligence to support that.
And definitely, if we can use it to inform preventative strategies, working kind of primary care, social care, public health, there's definitely opportunities there as well.
And I was going to suggest perhaps an exploratory conversation as part of Newham Sparks to see if there's something we could include within that programme.
Pick it up with you, because there's also some interest with UCL around some of this.
Yeah, absolutely.
Yeah. Sorry, go on.
Just looking to advance a personal opinion, if that's okay.
Please.
From the little I understand of integrated care systems and place-based working, one of the key things that makes them successful is good data sharing and proactive use of data. So I personally very much welcome what you've described at a borough level, and the higher you can put it on the authority agenda, the better, as far as I'm concerned, because it will play well to what we need to do in the local system.
Okay. I'll invite you to the event on the 22nd of September. Okay. I'll invite you all. Okay, thank you very much. Right, Wax, before I...
From a primary care perspective, where we've been using the data aggressively, especially during pandemic time, is around consultations, numbers of contacts. Close to, in Newham, 140,000 contacts with a GP practice over a month. That's not a small amount, thinking about GP registered population. And close to 30,000 contacts to our online portals every week, which is pretty significant. And over a month, that could almost become a million. So that's pretty significant. Trying to address that demand and need has been that we face where patients are struggling to get is not easy, and keeping up with that demand is something that we're using the data to make sure that we can do. The partnership between the local authority and health over the last 3 years, in terms of working with John and Jason's team, public health, who review our enhanced services. So we have our core work and we have enhanced services around chronic disease, diabetes, cardiovascular stuff. The public health team have provided data and supported with data and reflections and independent review of what we're doing. So those processes are already in motion. I think it'd be really, really useful. Though we are going on across North East London enhanced service kind of equalisation process, what matters for Newham locally is super, super important. And the suite of services, enhanced services, we've got an opportunity to build the right services. In the coming months, which I think is important, because in one borough, renal problems are not as prevalent, not as priority as another borough, where diabetes really, really is, a massive problem. So William coming next week, we'll present some of that.
All right,
which I think would be useful.
Thank you very much for that. Social care.
Thank you, Chair. I will try to keep this one brief. Like Andrew, I could talk for a while. So I'm just going to focus on two things. The first is just linked to what Andrew was saying around the activity at the hospital and the continued work that social care are doing as part of the integrated discharge hub. Whilst the numbers that Andrew's described, obviously not a low level, they are well within capacity of what we've been able to achieve via the work we've done collectively, not only with BARTS, but also with Elective as well as part of that hub and the CCG. So that continues. But the one thing I did really want to touch on, amongst other things, was the work we're currently doing with our providers in care homes around mandatory vaccination. So for everybody here tonight, the government passed legislation making it mandatory for everybody working in a care home or visiting a care home to have a double vaccination, not for visitors, but for any professionals that are going in there and the care workers, and that comes into force in November. So we've been doing a lot of work around with the providers, looking at their preparedness for this. So as part of the vaccination rollout, we've been doing lots of work around, as spoken about earlier, both care home residents, but also the care home staff. We have 25 care homes in the borough. At this moment in time, there's probably a couple where there are concerns about the numbers of staff that have undertaken the vaccine at this point in time. And we're working with them via both public health and via the CCG to give them the support they need. This is going to be quite a logistical thing for the care home managers to manage. So as registered managers under they will be responsible for making sure that every person that enters those sites is double vaccinated. And this has caused real anxiety across the whole of the provider workforce and nationally has been spoken about, especially, and I think if you think back to what Andrew was saying about the fatigue and people, using their feet as a voice in this sector, again, they have been really up against it for the last 18 months. And so there is a level of hesitancy and, we are expecting that there will be some members of staff who will leave because they will not be willing to take the vaccine. However, for most of our care homes, there is a good coverage in terms of the number of vaccinations that have been made, both in terms of first dose and second dose. However, the date for us to really keep an eye on is the 16th of September. And that's the date by which staff have to have had their first vaccination. If they don't, then that means that they would not be able to be deployed into the work that they do currently when the legislation kicks in. So that's really been a primary sort of piece of work that we've been doing in social care. But actually it's much broader than just social care, because obviously we have our own staff that have to go into care homes, social workers and the like. But we also, I was on the North East London call today, and we've got transport from ambulance services. We've got, GPs, we've got the whole plethora of different services that go into those care homes. And everybody's facing a very similar problem around making sure that those people are able to visit those sites. So really, I think I will stop there. I think the only other thing I will say very, very quickly is just back to Andrew saying about the levels of sickness, and in adult social care has crept up also. And we are now seeing some people that obviously over the last 18 months are now feeling quite fatigued. And, part of the wellbeing offer, I know the Elective offer, and the stuff that we're doing internally, we're doing that with our staff to make sure that they are as fully supported as they can be. But that is against the backdrop of us now moving into what could be quite potentially a very difficult autumn and winter period. So I'll stop there. Thank you, Chair.
Okay, are there any questions, colleagues? Oh, Colleen.
Thank you, Chair. Colin, I just do have a question just in regards to what you just spoke about regarding the care home staff and those people going into the care homes that are professionals. I just was going to ask the question in regards to what about staff that are community nursing staff, and those, does it include that cohort of staff?
Yes, anybody that's visiting a care home in a professional capacity, apart from, there are some caveats. So, if you've called an ambulance and it's an emergency situation, that kind of stuff, then you wouldn't necessarily need it, then it doesn't apply. But actually, if it's a district nurse with an appointment to come out to see some visits in a care home, they would need to have a double vaccination status.
What about if the patient isn't in a care home, the patient is a vulnerable patient community?
No,
so those, for instance,
it only applies to
care homes only. Thank you.
Yeah. Okay. I can't see any more questions either on the Zoom chat or hands up. So I'm going to suggest that we move on. There's a paper for autumn winter planning, ages 9 to 10. Who wants to lead on this?
So I'll do that one, Chair. I think the key points from this one are we're expecting it to be a challenging winter, not only with the continued impact of COVID, but obviously winter conditions as well as other respiratory viruses and illnesses. Planning is underway to make steps appropriate to the level of escalation we need to go to across all care settings, which the paper details, across both adults and children's services. And there are some really proactive things going on. So I think a good example is the multidisciplinary approach taken to children's mental health between the partners every week to try and support people not be admitted to hospitals wherever possible and to support some complex needs. And I think that will continue to be very helpful to support capacity in paediatric units and children's mental health units as well. So I think that's a really, really positive development. We had some announcements recently about money, which I'm pleased about because I think it helps fund some of the things we're used to funding, which makes this plan a bit easier, particularly around supporting people when they're discharged from hospital. Excuse me. But just for the Health and Wellbeing Board to recognise that the plan is underway and will be completed by the end of September.
Okay, are there any questions? Do you want to add in? Yeah,
a question, actually. It might be a really stupid question. Where there are staffing shortages and challenges, does money help?
Yes and no. Money will often influence a decision on that night, and I have a personal experience of this. I have to sign off the rates of pay for anything that exceeds our standard rates of pay. And at the moment, everything does, so I sign everything off, and money does talk. And money doesn't help in the long term, though, because it persuades people to do work when they're tired and exhausted, and then they come back the next week and they're even more tired and exhausted. So chasing the rates in this situation, I don't think is a long-term strategy. It helps us out of a tight spot, but ultimately self-defeating.
Okay, Zulfikar and then Carl.
Very quickly, thank you, Chair. It's good that the good work is happening across the there, but I hope at some point after the end of March, end of September, we will see action plan which will clearly showing which partners actually responsible for what, so that we have a proper execution plan.
Absolutely, yeah. So one of the key challenges in the NHS side is there are particular elements of these plans that the NHS nationally wants to see at the end bit in the NHS. So we haven't had that yet to know exactly how to construct it. What I'm pleased about is I think we've tested our escalations very well over the past 18 months to know some of the things we are capable of doing and some of the requirements we have out in our communities as well as within hospitals. So I think it will be similar to plans we've executed in the recent past. I'm very happy to share it when it's complete.
Carleen.
Thank you, Chair.
And Wax after. Yeah, Carleen, go on.
Thank you, Chair. I guess my question's going back on the same principles we were talking about earlier in regards to staffing. Just thinking about winter planning and the coming winter, we know how bad winters can be anyway. But I guess what I'm asking for is some assurances that if this is a bad winter and we do continue with staff shortages, I guess my question is there a plan B?
So I think what our winter plan does tell us is how we react to different levels of risk. And that is either issues around our ability to supply care or the levels of demand we're experiencing. And it gives us places to go. So sometimes we have to replace one thing with the other. So we have to create more critical care capacity, for example, or we might have to move services from one site to another as a result of that. I think we have to recognise we approach this pandemic with what some would describe as a workforce crisis in health and care. I think this has compounded some of that. Even if we had millions of pounds to invest, I don't think we could suddenly find lots of nurses and doctors to expand capacity massively. So I think it is about managing that risk and making safe choices. And that's what this planning is about, is our ability to make safe choices, recognising the scale of risk we're facing.
Thank you. Yeah, Wax.
Colin and myself have been involved in these plans on and off for the last decade. And, you know, when it comes to reviewing what's successful and some of the things that we've touched on in terms of who's using A&E, ED, and who should be seen in primary care, increasing or providing appointments in primary care above core, which we have done, although I'm not too sure what's coming. Is there any plans for that? Primary care is working quite heavily on that, relying quite heavily on the local resource and appointment with face-to-face with a GP or over the telephone. It's always going to be smarter use of NHS money over such a difficult period, especially when those who are more complex need that hospital setting. So I'm just wondering, in any of the discussions, some years we used to provide up to about 110,000 appointments throughout our hours and our hubs. So are there any plans to provide those numbers of appointments or any kind of appointments in primary care or resource to be able to support the rest of the system?
Okay. Anyone wants to comment on that? No?
Well, I suppose that will be part of the planning that we do. When did you say it would be finished, John?
By the end of the month, yeah.
So I think that would be part of consideration as part of that, and suggest that we bring that plan back in November. So
I think it will be out of date because it needs to be submitted to NHS England in October.
yeah, not the submission, just I think it goes to Councillor Ali's point about who's doing what.
Right, okay.
The election.
Part of that plan, yeah.
Right, fine. Are you satisfied with that? Oh, yeah. Okay. And just in terms of the draft plan, that will be circulated amongst partners by the end of September, and then will it come back to this board, not necessarily for consideration because it will have been submitted?
Yeah, that's what yeah.
Right, okay.
Yeah, so what we can do is bring that plan back to November, but it would have been circulated previously to colleagues involved to make sure that they're aware of it. And what happens is get round and talk about the different things that we can do. There's already, as John said, escalation points that have been used as part of the COVID-19 response, so whether that's about the use of community hospital space for COVID-19 patients, etc. It's all of that kind of stuff that we'll make sure is built into that plan. But I'm sure, John, that's not a problem to bring it back in November, is it?
Not at all, no.
And can I just ask, where it says in the report, members of the board and partner members are asked to contribute, so there's a process outside of this meeting to enable that to happen. And then I was just quite curious around the continuing to develop NHS 111 as a first point of triage. What is the position presently? And what particular areas need to be improved? I mean, it seems obvious because it's just a phone call, but I don't know if there's language barriers, et cetera, et cetera.
So I think it was this is based on a national programme of trying to encourage people to use 111 before they say turn up at accident and emergency.
Right.
And encourage people that is a good way of getting lower level needs supported, or indeed get access to different appointments from a range of different health professionals. So I think it's just a continuation of that programme to use 111 as that non-urgent line for people to access healthcare.
Okay. Oh, sorry. And Wax, Andrew.
It'd be good to see in November what's being implemented, and then we'll probably review the new year what wasn't implemented. And then on for primary care, from a primary care perspective, on each GP surgery is practically 1 in 500 of the appointments. So for every 500 patients, one appointment has to be open to 111, so they can access that.
Okay. And Andrew.
So the other opportunity with 111 is this service called The Beach, which was developed by Parks Health and Ambulance Service that won an NHSJ award last week and has been highly commended, which is a service by which paramedics can call an A&E consultant and discuss the case with them, whether decide on home treatment, GP disposition, other treatment, or bring to hospital. It also means that patients are expected at the point at which they turn up at hospital. We can increase the use of that to make better use of it as we understand it and develop it further. So there's stuff with 111 we can do that will help, and a lot of it's in train already.
Yeah, sounds really interesting. I was actually quite struck with the ambulance service utilisation. Right, okay, I've got elective recovery update. Yeah.
So I can brief on that.
And then that's me. You've only got a half an hour to go. I'm so sorry.
I won't talk very long, a couple of minutes perhaps, but I'll just describe the context, which is probably a bit of a rehearsal, but it's worthwhile repeating in case there's been any change since the last time we spoke about it. And then a description of where we currently are. So at the moment, we have a trust-wide elective recovery strategy, which is predicated on the surgical strategy started to develop before COVID happened, but it actually has responded well to the COVID test. So at Newham Hospital, we're currently doing almost exclusively orthopaedic elective surgery. And as we bring 2 further theatres back into use, and I'll describe the process by which we're doing that, in November, we'll start doing gynecology and general surgery elective surgery. All elective surgery in Newham Hospital will be what's called high volume, low acuity, low complexity. So that's lots and lots of cases, the easy ones to do. Complex cases will be done elsewhere. And just for context, Whips Cross Hospital will be doing our ophthalmology, ENT, urology, some general surgery and our hip fractures. And Royal London Hospital will be concentrating on cancer, any complex surgery, and of course trauma and neurosurgery. At Newham Hospital, we currently have 4 theatres open for elective surgery in the Berks Health Orthopaedic Centre, which is in the Gateway Centre, in a freestanding building, which many of you will have seen. We also have 3 theatres open in the main site. 2 of those are obstetric theatres to service our maternity unit, and one's an emergency surgery theatre to service any emergency surgery activity that comes through. However, as part of our fireworks programme, in response to concerns raised by London Fire Brigade, we have 2 further theatres opening in November, and that's where we'll locate our high volume complexity, gynecology and general surgery activity. The fireworks will also deliver 2 day case wards, so 20 additional chairs available to service that extra elective activity, provided we can of course staff them. I'm not rehearsing that discussion again. Staffing is the precious resource we're all scrabbling for. And then finally, in terms of the future, we have 2 other mothballed theatres that haven't been used for over a decade. And we have seed funding allocated to establish what capital costs will be required to bring them back online, with an expectation that we will get awarded that capital funding and we will be opening them hopefully somewhere between Q3 and Q4 of the next financial year. But that's dependent on, of course, the capital allocation and whatever emergencies happen between now and then that might divert capital allocation. So the risk to delivery of that strategy includes the mobilisation of the surgical strategy, which is a large-scale change in the way we provide surgical activity, but good context in which to do it in terms of COVID. Anaesthetic staffing, and we are particularly short of consultant anaesthetists to staff our sessions, and that's in line with the national shortage of anaesthetists, which will potentially be a limiter for us. And then general theatre staffing. And the mitigations to meet those risks include the surgical board, which works actually at a regional level as well as a trust level, and the clinical networks, which helps us to mobilise the surgical strategy. The establishment of a specific perioperative care network or anaesthetic network to address our group-wide anaesthetic demand capacity mismatch, a fairly significant recruitment campaign for anaesthetics, and also investing in provider collaboratives to make sure that we have anaesthetic resource more sufficiently across the region. Now that mitigation is as yet incomplete, but it's going a long way to resolving some of the risks. And finally, we have a recruitment campaign for general theatre staffing. We are currently rebanding our operating department practitioners to retain them, even less than another hospital. So to retain them by that exercise. And then finally, we're using the independent sector fairly extensively and increasing our usage again of then support surgical pathways for some key high-risk services. In terms of our current performance, we currently have 35 patients on our hospital waiting list who've been waiting for 104 weeks or longer. That's just jumped up by about 15 or 16 patients, but that's because we've recently done a data cleanse. So there's not been any other activity that's happened, it's just we've done some work on the data and the numbers have shifted slightly. And that's also been compounded by some reduced capacity over August associated with annual leave and vacancies we've discussed previously. The 52-week story is a good news story. So from a starting point of around 2,000 after we emerged from the winter, we've got down to 1,059 patients against a plan of 1,400 patients. We're beating our own internal plan for 52 waiters. And of them, 347 are waiting for inpatient care and 700 waiting for outpatient appointments. There is a fairly extensive specialty by specialty report, which I can go into if anyone's got any specific questions, but I won't go through that routinely for you at the moment. I'm happy to take any questions on that general recovery plan.
Councillor Ali.
Thank you very much, Andrew. It's helpful to know how the numbers are going down, which is showing good progress. Is there a kind of, I mean, we don't know what's going to happen in winter in terms of the COVID impact and the flu, etc. But is there a plan when we're likely to go back to catch up with the backlog and, you know, in terms of time scale? I know numbers are going down, but what is the target, for example, next 4, 5, 6 months in terms of reducing these numbers?
Yes.
Being in mind you've had a number of constraints, as you mentioned, about resources, capacity, and possibly, bit influx in winter.
Yeah, so there is a month-to-month plan per specialty, which tells us we've cleared our long waiters, 104-week waiters and 52-week waiters. The trouble is that's a moving target, so it's difficult to track at times. And is also, as you've alluded, acutely dependent on what's happening at the front door. Different specialties differ. Some are projecting a clearance next summer, some are projecting a longer time before they'll clear. The specialty trajectories for clearance aren't, unfortunately, we're not sophisticated enough modelling to make them mutually dependent. So they're done on with a fair word behind us principle, being able to model it accurately. I think that the best strategy for us at the moment is to work week by week, month by month, making sure that number continues to go down and keeping it as low as possible, trying to beat our own internal target as far as possible, rather than chasing an eventual trajectory. But it was the question I asked myself when I was preparing to come here, was when we expected to clear completely, and I couldn't get a firm answer for myself, and therefore I don't want to mislead the board by giving you a figure that is potentially not correct.
And just quickly, how are these numbers going up in view of further referrals, or bearing in mind that you now started giving people appointments, etc.? So that you've got the backlog and you've got the new cases coming through. So how are they impacting on the strategic plans?
Yeah, so there's a complex interaction between the admitted and the non-admitted elective backlog. So the non-admitted elective backlog is, of course, the outpatient backlog, and that's dependent upon GP referrals and how fast we can see the outpatients. The admitted elective backlog is dependent upon how quickly we can do operations, the number of GP referrals for new operations, but also the number of outpatients we see and decide to do an operation on them. So that's a more complex piece of modelling.
Thank you.
Yeah, Wax.
And really good to hear about cementing great volumes of surgery, world-class surgery at the site, which is fantastic. What is the potential impact on the ED department in terms of opening and the kind of patients that the ED department will be able to see, especially taking into account the anaesthetist vacancies, etc., addressing trauma calls and arrest calls and stuff, and the moving around of surgical services across the Barts Health footprint.
The provision of a fully functioning comprehensive emergency department is a line in the sand for us in terms of the surgical strategy. And any re-provision of surgical services has to be dependent on providing sufficient out of hours cover for anything that might come through the door in terms of surgical activity. Now, there are ongoing discussions which eventually come back to the same point about whether we can redirect ambulances with particular presentations to other hospitals. But that's incredibly difficult and doesn't actually solve the walk-ins and solve the more subtle cases. So the bottom line is we'll have to continue to provide a comprehensive ED department. And if we can't do that, if we can't reorganise surgical services to do that, then the surgical services will have to stay at Newham in a more traditional format. I think we can do that. We've got a good plan, for instance, for acute general surgery. It means we can meet that, which I've described to you.
Okay, and I've seen Colleen.
Thank you, Chair. It may not be a question for you, but it just dawns on me in regards to elective surgery. Is this the same principle with oral health and dentistry?
So I can't comment on community dentistry, but we do have a plan for particularly paediatric dentistry, which is done in tertiary care, done at Royal London Hospital, and from maxillofacial dentistry as well. So it covers all dentistry services that are provided by the trust. There'll be a different plan for community dentistry, which I'm not citing. And there's a really exciting piece of work happening for paediatric dentistry, which involves the building of 3 theatres at Royal London Hospital to meet quite a challenging paediatric dentistry backlog called Project Tooth Fairy, which isn't my description, but I wish I had thought of it because there's a brilliant name for it, which again is staffing dependent, but will go a long way to that.
Thank you.
I can't just let that be said without saying that we need to do an awful lot in the borough to try and prevent some of that child oral surgery, a lot of which is those extractions are entirely preventable by getting our prevention better.
Yeah, actually, it's an item that I wanted to raise. Rima, who did actually notify notify us that she wasn't going to be able to make this evening's meeting, sent an email to the three of us about the issue of dental practices and issues of access, and it's getting quite critical now. So we'll pick that up under the oral health update as well. So I'm going to suggest that I hand over. I don't know how is this running until 9:30?
I'm usually extend the meeting. We've got to finish by 9 o'clock ordinarily, but if you vote to extend, we can go up to an extra 30 minutes.
15 minutes to 4:15. We've got 1, 2, 3, 4, 5 agenda items.
Let's see them.
You can complete it by 8.
Who's taking item 6?
I think
Tim.
Hi there. Sorry, did you want me to take item 6?
Yeah, please.
Sorry to keep you waiting, Tim. It was Wax's fault. He kept on asking too many questions when I was chairing and I was being polite.
I can believe that, absolutely. Now, thanks for this. And I'm not going to take any credit. I know that Geetha is very involved in this item, and we've also had support from Raka from the public health team. And this is all about bringing together a whole range of services in order to provide a better experience for children and young people and their families who require mental health services. I know we've got John Wells as well from the local CAMHS service here for this item too. So it's great to have you here. So I think in the slides it sets out the approach to bring together, as I said, a range of services and to smooth that pathway. And that's all about making sure we are making best use of services during a time when we know there is a real challenge in terms of the capacity, the ability of services to respond. So, Geetha, I don't know if you want to say anything more in terms of the delivery. Otherwise, we can take questions on this item.
Yeah, just a couple of things, if that's okay. I think the main thing really to say is that this is about the whole system's response to mental health and well-being, and really what we are trying to achieve is that much more consistent access, and also to enable access to be at multiple points, so we're not always waiting for crisis. And I think this is really quite an exceptional piece of work at a time when we know that young people's mental health and well-being, and obviously the impact on COVID and other things pre-COVID, or cumulatively, is something we have to pay really mind to and really big attention to make sure that our young people are best supported at all parts of the system, not just in therapeutic services, whilst we know that that's also very critical. So thank you very much, and happy to take questions. Thank you.
And just I'll finish by just saying, yeah, it brings together that range of voluntary sector providers, some of the, if you like, the lower level early help approaches to responding to the needs of children and young people. And it's one of many areas of work that we're doing across the system. I think John mentioned it before, but there's been really significant join up between colleagues in health, the CCGM providers, and those working in social care and across the council, in really trying to unpick and resolve some of the real challenges we've got in terms of care planning for children and young people with really complex needs. And that's particularly illustrated in some of the work we're doing around diverting away from tier 4 or stepping down from tier 4, which is inpatient mental health provision for children and young people. John, I don't know, or Raka, I don't know if there's anything you want to say to provide further sort of detail on this before we take questions.
Good evening, everyone. I think just to add one thing that most of the kind of like the system response is like building on existing infrastructure and existing services that we had in place and that were established as a response to the pandemic. And what we're trying to do is just kind of bringing all of this together and integrating this into one single children, young people, mental health and well-being single front door. So any young people or family or professional who kind of notice that a young person is struggling with mental health needs, then they know that this is the kind of only way to get into the system, and they don't need to kind of go around and get lost across the many services available. So yeah, I just wanted to highlight this, and again to say that this has been a really kind of partnership working across public health, TCG, children's services, Brighter Futures, and primary care as well. Thanks.
Maybe I can just add a couple of comments that, you know, from a CAMHS perspective, this has been a real game changer over the last 6 months. We all know the impact of the pandemic on young people's mental health, and the double whammy was that often the referral routes got severed. Schools were closed, GPs were limited in what they could offer, and so the young people's needs were increasing whilst their ability to be referred through to CAMHS was decreasing. So it was a major issue for all of us to really think about. And the development initially of NUMAC panel was really to look at the young people's needs who were going to have to wait longer than they would traditionally have done because of the increase of more severe presenting problems with more young people. So those young people with which we would rate as green or a routine young people were having to wait a lot longer for their care. And our worry was that their needs were going to increase because we weren't able to see them quick enough. And so we'd reached out to our partners across the community to sort of say, how can we all work together to meet the needs of the young people who are waiting? This was almost an explosion of excitement and interest in this across all the agencies. And within a matter of weeks, we had a weekly panel which has been attended by upwards of 25 plus different agencies, sometimes in the same week, all looking at our routine cases, looking at their needs and offering care packages to help them while they're waiting for their CAMHS initial appointments. So this is where it started. And it's, I think in the 3 or 4 months we've been doing, we've presented over 125 different cases and have come up with, I think, packages, immediate packages in some cases, the same week they were referred to us, up 99% plus of those young people. It's been such a success that we're now moving towards it becoming the basis for the single point of entry, as Rak was just talking about. It seems to be a no-brainer. The next stage is to really use this infrastructure that's kind of suddenly materialized as a formal way of coordinating how we help young people with their mental health needs going forward. So I probably spoke more and for longer than I was intended. So,
thank you, John. No, thank you. And it really is the product of lots of really effective collaborative work across agencies. And I just want to say a particular thank you both to Raka and John on the call, but also to Philip Williams, who's done a great job in steering some of the multi-agency conversations during the pandemic and beyond.
Absolutely.
Thank you, Chair.
That's you, you're cheering.
So a huge thanks to everyone involved. I think it is a really, really impressive piece of work. I'd be really keen to later in the year, in 6 months' time or at an appropriate point, to bring it back to see the impact and both on some of the outcomes and but also some of the feedback that we're getting from and the experience feedback that we're getting. But I think it is really impressive, and I know it's going to take, the next phase is going to take bedding in, and there'll be but yeah, it'd be great to see later in the year how it's getting on.
Yeah, we'd be delighted to come back and present that.
Thank you, Chair. As Jason said, this is an excellent example of joint working to tackle the issues that we are facing collectively here. I know that there is some baseline figures in terms of assessment waiting times and treatment waiting times, and I just wonder what are the sort of key outcomes that we are collectively going to measure, and how those accountabilities will be monitored. Sort of how will we judge our success in 6 months' time or a year's time? That is in there, but it's a good model, and presumably that's something we worked on. But it'd be good to know what those things are.
Thank you. I think the initial targets were to ensure that the young people who are waiting, who are considered routine at point of referral, their mental health needs didn't get worse while they were waiting. And so that they could be offered things like mentoring, youth service input, access to sporting activities, creative activities, often helping to improve young people's confidence, their self-esteem, all of which we know often feeds many presentations of mental health concern. And so we were hoping that those young people, while they were waiting, would still be offered their CAMHS appointment. By the time we were seeing them, that their mental health would have improved because of the very sort of real world normalized kind of help that they'd been having access to while they were waiting. And so that's really what this was about, to try and put those packages in place as soon as we can in the young person's journey into CAMHS, rather than waiting 3 months, having the assessment, and then trying to set up these packages of shared care. So yeah, we would hope that the routine cases, many of them may not even need CAMHS by the time they're offered their appointment. It also frees up space to offer quicker appointments to those amber and red cases where there's real safeguarding concerns around their mental health. So they would be the two targets we'd be looking to see improvements on.
I just come back. Thank you very much indeed, John, for that. I mean, my next question really, in response to what you just said is are there any resource implications, and how are we going to make sure that this system is sustainable in the long run?
So that's going to be the challenge. I think we've got some funding for the 2 lead posts that we're recruiting to at the moment. We're going to have a CAMHS lead and an LBN lead. So the key parts of the system will have a leadership dyad. They'll be working to set. We had in our slides, we had a sort of project plan, which we won't go into, and we don't have time. But they'll be rolling that project plan out. We would hope that this model will be demonstrating that it's so effective and so useful that it will be mainstreamed. But at the moment, we're looking at fixed-term funding just to try and get the project off the ground. As I said before, it feels like a game-changing moment, and we would hope that that would be integrated and supported going forward.
It was just a quick question, really, and thank you to everyone that's been involved in this really exciting initiative, and I'm really taken by the proposed new single front door, and very interested in the MAC acronym, albeit it sounds like McDonald's. I'm sure it's not. I just wanted to ask, I'm assuming that thinking has also covered off the way in which access to this front door can also help identify those that may be at risk to a range of vulnerabilities, particularly thinking in the context of our borough-wide youth safety piece, but also most recently some of the conversations that we've had with regards to the vulnerabilities and risks of violence against young girls as part of the wider crisis that we are facing, not only in the borough, but also across the capital in terms of violence against women and girls, and whether or not there's been a consideration of those elements as part of enabling a pickup of young people with exposed to that risk.
Absolutely. I wonder, Rachel, did you want to say a little bit about how the front door mechanism might work in the model, in terms of it being essentially a gathering in of any concerns about any young person at one point?
Yeah, so the new kind of proposed model is suggesting that any young person struggling with mental health and well-being, or any kind of friends, family, or professionals noticing this young person struggling with some sort of kind of well-being needs, then we would have like the guided self-help, which is basically the online directory of services, which has all the services available that could support this young person to access the support he needs. if he needs kind of that extra level of support, then we are also offering the chat health service, which would be a text messaging service where he can just text the call handler and kind of get his way through the system, and then gets referred back to the single front door. And then the other direct way would be just the young person or the professional directly referring this young person through the single front door, which is kind of the partnership, the collaboration between the MAC, the Your Time, and CAMS as well.
So essentially, maybe to connect it to your question, if a teacher, for instance, had serious concerns, let's say about a young man and how he was presenting at school, maybe his behaviour was of concern, then they could seek, they would be encouraged to speak to their embedded CAMS worker in the first instance, because we have a number of those across the borough, but they could also seek advice from the helpline and the single point of entry, have a conversation, theoretical conversation in the first instance even, about their concerns, and then they would get guidance as with regards to where they go next in the system. So what kind of help might they need? What kind of consultation may they need? Where could that lead to in terms of assessments, maybe specialist assessments being provided? And then at different points of the system, that kind of MAC stands for multi-agency collective, by the way. That's the acronym. We added U to the front. So it's a new MAC, just to be clear that it wasn't any other kind of MAC.
And just to add to this, that we've started collating some of the feedback coming back from the organization that are supporting these young people and the young people themselves or their families. And a lot of these concerns are going beyond just kind of mental health needs. So it's kind of covering some of the stuff that you've just referred to.
I don't know if I could just add on the gender piece. I think it's really important that the early help pathway is one of which the young people will be and families will be able to access. And of course, a gendered response in terms of interventions is absolutely what all of that service is doing. And it's part of the early help offer to make sure that we have specific interventions for young girls and women, because we know that that is absolutely vital for them to feel safe, but also to be able to engage and have the right level of intervention at the right time. So all of that is part of the offer. And as John and Rasha have said, it's all very bespoke in terms of the family and the young person's needs. And that will be under review. Thank you.
Yeah, the ambition is to ensure that the directory and the helpline has access to every single offer that's provided by every single agency in the borough. That would be the ambition. And it could all be held in one place and can all be accessed by anybody who's interested or keen to find out how they can be helped.
If I could just add, we are reviewing our sort of front door of children's social care and early help. And this is a really good initiative that will align really well to some of the changes we want to put in place. So it's truly a sort of integrated front door across a range of services for children and young people in Newham.
Carly.
Thank you, Chair. I just had a question in regards to the pathway we're looking at, how it interacts with the pathway that looks like it's under development for children with complex needs, and how do we not lose any children in the midst?
So do you mean in terms of potentially doubling up or bits of the system providing?
Yeah, I guess doubling up, but also some children may present in one area but really need to be assessed in a different area. Do they go back to the back of the queue? How does that all work? I'm also thinking about those young people that often will encounter mental health needs that are young carers.
So, I mean, we're hoping that the plan would be that the helpline would be able to triage the initial concerns or the initial query, and would then have access to a range of options in terms of what the next step would be. So we would be obviously developing that part of the system to ensure that it's logical and fluid and goes down a logical progression in terms of understanding the presenting needs of the young person. And we would have a multi-agency kind of steering group which would be advising the development of that part of the service. But I think it would be important to build in those kind of feedback loops throughout the system, so that if a young person is going down one avenue and it's clear that that's not the avenue that's going to be of most help, that can be reviewed and there could be a diversion built into their care plan.
Yeah. Thank you.
And so if I can add, also there's now a regular conversation between colleagues certainly in social care and in the CAMS service around some of those those young people who are presented with more complex issues, to make sure we are avoiding sort of either duplicating or not working in an aligned way with that family. So there's a lot of work going on to make sure we're both using resources effectively, but we're providing the very best service we can to that young person, their family.
Thank you.
So I think it's frankly superb, and I thank everyone for their efforts. I think what we're keen to do, particularly around the outcomes, is think about what outcomes we're achieving for individuals, what it's like to be a member of staff working in this, and how they feel they can do their job better by working this way, because I think that's vital based on some of the comments Andrew's made about workforce, and as well as what we're achieving overall for the population. And I think this is a really important step in thinking about the front door, but then what sits behind that and how we do that better in partnership, particularly as we look at the needs of over the coming years and the population growth we've got in younger people, is building a resilient offer that enables people to move through different levels of care and support from a variety of different agencies, including voluntary and community support as well, to make sure that we are sustainable in the longer term. And so I think we've made a really good start on thinking about how we do that in partnership.
Thanks, John. My questions were, how is this single front door resourced in other boroughs, and what do we need to make this sustainable? Secondly, how does the information feed back to primary care? Because looking at any of these agencies on there, apart from CAMS, I never hear from any of the other agencies. So there's a breakdown in communication potentially, especially when Dr. Vader's commented repeatedly about the number of presentations we have in primary care. And then just a point of clarification, our neutral self, GPs have never been closed.
Yes, absolutely.
So the communication back to primary care and then resourcing this going forward.
So the next step is to recruit the leads of the two arms of the project, and they will be developing that part of how the system works. So questions like that will be factored into the planning going forwards. And apologies if I seem to indicate the GPs had closed during the pandemic. That wasn't my intention.
I have to take a position sometimes. I'm sorry.
It wasn't my intention. It's not what I think either. So.
And I don't know. Sorry, Rasha, do you want to cover the sustainability point?
Yeah, I mean, I guess it's kind of like a project still in development, so we won't be having like all the kind of answers to it. We will be bringing back in 6 months' time, like the development work and how it's going and the feedback and the kind of impact and outcomes it's producing. But what I can say, like across, especially across NEL, because this is kind of a piece of work that is being fed across Northeast London, we're really leading the way, and other local authorities are coming to us asking how we're developing this. So yeah, but we will bring back in 6 months' time a report on this.
And I was just, in terms of what Rash just said, while I think lots of places have done work around single front door, the incredible integration of community and voluntary sector and the more kind of social side of this into this work is really, that's cutting edge.
So could I just add one thing on that? Because it's really lovely to hear this. You very often hear about holistic, swift responses and the impact they can have on young people, and bringing together health input, social input, a much broader set of agencies. I do think, particularly if we can track the outcomes here, the impact on young people, their experience of this, there's a lot of information in there for treatment going forward. But in terms of the sustainability question, we will see, I think, I would put quite a lot of money, if you like, on swift response that actually engages with the young people as early as possible in as integrated way as possible will probably start to change the pattern of crisis delivery, which as a trust, we've seen in 1 year, the number of crisis cases per month go from 50 to 350 a month. This is the sort of intervention that I think will change some of that pattern, because you cannot underestimate a really swift, holistic response, young people, their families feeling heard, potentially feeling held, feeling more effectively signposted to the right place. So really just honestly, to echo everyone else's thanks and just the real importance of seeing this through. But there is a sustainability, there is real hope on sustainability, I think, there, because obviously there's a lot of resource that goes at the more intensive end of the pathway that we would love to re-engineer back to supporting this sort of work.
Thank you.
Okay, brilliant. Thank you very much, all. It's brilliant. Thank you.
Thank you, everyone.
Thanks, everyone.
Item 7. ICS.
Yep. So the NHS has decided to reorganise itself once again, which it's been about a decade. So yep, it's time. So you could see in this paper some real positive elements, which I think many parts of the statutory sector, health and care, have been calling for, which is a more joined up to way to planning and delivery of services. And I think the NHS is trying to adapt its structures to make that work. We see the creation, subject to legislation, of the integrated care system at a NEL level, which will receive the responsibility for money for the NHS and responsibility for the performance and quality run through it. And as part of that, to help it do its job well, we see the formation of provider collaboratives from an NHS perspective. So that's groups of hospitals or trusts working together to advance outcomes. And I think when we look at the topic we just discussed, some of that will be about how do we deliver our most specialised services, but also how do we start to think about putting our investment in slightly different parts of the system, not necessarily the traditional, more specialised, high-cost elements that we've done. So I think that provider collaborative is really important for that, and really important for some of the things Andrew mentioned about surgical services. Where do we deliver high volume, lower acuity work across the patch, and where do we focus our fewer specialised surgical interventions to have the best outcomes? The other element which is placed great emphasis upon is around the place-based partnerships, to be that local connection with communities, through communities, bringing the best of the statutory sector in combination with voluntary and community and faith sectors, to think very carefully about outcomes for local people, think very carefully about inequalities, and those things that really do need to be done at a very local and personal level. So there's huge emphasis on that. I think from a North East London perspective, it looks at the 7 boroughs it's got and really wants high-performing partnerships in each of them. And I think there's not a huge amount of guidance or detail about exactly how those are formed, because we know that you can't legislate for good partnership working. Legislation doesn't give you some of the examples we just saw in the last item. So very, very, very keen that we develop our partnership focused on the integration of services where we need to integrate them, and very much orientated around outcomes and inequalities. So the paper just describes some of the impending changes. I, personal opinion, think we are well set to develop our borough partnership and for it to go strength to strength, but also to start to say what we want from a new integrated care system that we can only do at a broader geographical level. So I think some of the things around workforce planning, supporting the gaps we might have in anaesthetists or others, making it a really attractive place to come and work. So we could do that where we need to do things at scale. So just an update really for the Health and Wellbeing Board on the progress being made through Parliament and the local arrangements we need to put in place as provider collaboratives and our borough-based partnerships.
Any questions? Colin?
Mine is more of a comment, thanks, Chair. Just that obviously this is a landscape and there's still some guidance that's due to come out and we're still waiting for clarity on certain parts. But certainly from a borough-based partnership point of view, it's the, as John's put it, I think there's a really good opportunity there to shape the future and therefore think about how we really work together in that partnership. And I think the last item really highlighted that, and a lot of the other work that we're going to be talking about later on. I suppose it's really just to say that as it does take shape and we are much clearer in terms of the intention that we will want to bring that back to Health and Wellbeing Board for support. And I know that, yourself, Chair, the Mayor, Councillor Ali are involved at a North East London level with all of us around sort of the collective and virtual table here tonight. So really it's about just showing the status as it is at the moment, but then also acknowledging that we will have to bring this back as we firm up those plans to really, we certainly see the Health and Wellbeing Board playing a pivotal role in how that borough-based partnership is held to account and the relationship between, say, our health and wellbeing strategy and the work that our borough-based partnership undertakes. So really just to say this is a bit of just an update for the board and that we will be bringing further information back.
Councillor. Thank you, Chair. I think Colin has summed it up. Clearly there's more guidance is coming through as we go along, but there have been a number of meetings at different levels discuss the governance arrangements and the role the local authorities are going to be playing at the ICS board, plus also the borough-based partnership, and what they're going to be delivering and how open and transparent and working relationships are going to be truly in the sense of, openness, and the way we're going to work together. But I suppose the issue for this Health and Wellbeing Board is what is going to be the relationship of the ICS board with the health well-being, and where do the accountabilities lie? And I think there is a bit of lack of clarity at this stage on that issue, and it's something perhaps we need to think about and look at and see what best options there are for us to consider whilst we're still waiting for the government's final legislation. Clearly there are going to be constraints in terms of the NHS, but certainly I think the working relationship with the current chair of the ICS board is very good, and at even at official level, I think they're good partnership working that's going on. But from this board's perspective, we do need to clarify a bit more whether what will be the relationship and who will have the governance oversight, etc., and accountability. For example, if ICS board decide to do something which Health and Wellbeing Board doesn't agree with, or vice versa, then where is the red line? And I think those are the issues we need to look at. I don't know whether there's a need for some discussion amongst the Health and Wellbeing Board member to see what they would like to see reflected within the governance arrangements to make sure that there's clear lines of accountability and relationship, that there being any cloud. Thank you, Chair.
So I'm going to come back with a question. What would the Health and Wellbeing Board like to see in terms of governance? Because it's only got and I can't see much more coming out, specifically on the point that Councillor Rowley's talked about. What do we see the role of local authorities in the ICS, and
I think
what do we want as a role?
If I may again, Chair, I think what we need to look at is based on what we know, what will be the impact of the current guidelines or what is being suggested as part of the makeup of ICS board and the local partnerships on the health wellbeing board. Our term in terms of references, we need to perhaps review those in light of whatever happens with the ICS. And so on that basis, we need to know exactly what ICS proposals are, and then how do they support, complement, or contradict what we're trying to do in terms of the existing, the terms of reference of this board, in terms of accountability, governance, and relationships.
I was just really going to add, building on what Councillor Ali has said, and I think it probably warrants a sort of, a further conversation with more time at an appropriate point in advance of things being cemented. But for me, it's a really important issue around local accountability, and then issues around proportionality and an equity across the integrated care system, and how do we ensure that that is respected, acknowledged, understood, and then responded to, and who is it that we hold to account if it's not, or if there are signals that it's dissipating. Because what I want to avoid, and what all local authorities want to avoid, is a kind of tit for tat amongst the local authorities scrabbling for scarce resource when it comes to a critical need in terms of the health of their respective populations. And we can't allow for the system to lead us down that path.
Yeah, for me at the moment, the challenge really is when CCGs merged, there was a clear principle around that 80% of this stuff was going to be looked after locally in terms of resource and also people power. I'm not seeing that right now, especially in terms of some of the vacancies we have in terms of CCG. What happens when CCG goes 31st of March. And there is a shadow period before that that we need to tackle. But those are the kind of questions, verifiers, that we must pose to Marie.
I think the intentions are good, Chair, but clearly, as you said, we need to make sure that they're going to be translated into action. I mean, from local authorities' perspective, we have 7 boroughs. So what we did is we set up a small group of myself, leader of Pickering, Mayor of Tower Hamlets, Mayor of Hackney, to look at the local governments or the council's perspective. And we made some suggestions which were considered last week, and then there will be further discussion earlier on next month, where we formulate what the local authority position is. That is more in terms of representation on the ICS board, the membership, and the accountability issues as well. But I think we just need to make sure we continue to explore those discussions to cover the wider interest of this partnership.
It'd be useful if the action points for those discussions
I'll send it.
So what is heartening, I think, is the latest guidance from NHS England on this, which talks about in excess of 80% of care is delivered locally and organised locally, and that principle of subsidiarity needs to come through in whatever happens at place, because that's where we connect with people, that's where we have the most impact. So I think that sort of 80-20 rule you talk of, Chair, is very much expected, that subsidiarity is there because we want to empower our frontline staff to have the best impact with local people, and we do that. I think the health and wellbeing boards remain in the draft legislation for a very good reason, because it's the combination of partners, both politically and in terms of administration, coming together to respond to those local needs. And I think that accountability to the health and wellbeing board remains for whatever we put in place in the borough, and it should be continue to be strongly recognised as part of that. So I'm finding some of this quite heartening. I think the formation of councils working together across North East London, I think again can be quite powerful, because that's going to be built into the formal governance, and I think that helps with the IBIT and all the ICS or ICP is the integration of health and care, and I think that is going to become a much more formal part of how the NHS governs itself alongside social care across the population. So I think could could be quite powerful for us.
Just ask a clarification. Thank you, John. I mean, you mentioned the Wellbeing Board, and that is a legislative role. Is that likely to change in light of the latest ICS legislation?
No, it remains as is. I think all it does is switch CCG, which under the new legislation is abolished, and says Integrated Care Board, which is effectively the executive of the NHS at a North East London level.
Thank you.
Colin.
Sorry, Tim Aldridge wants to ask a question.
Tim?
Thank you, Chair. Thank you, Colleen. Yeah, my question really, John, absolutely appreciate what you've said in terms of the importance of good local collaboration and working relationships. It was just certainly in conversations with the other directors of children's services across the footprint, our concern was really just to make sure we've got the right level of focus and representation on the governance on children and young people. You know, absolutely recognise there is a significant focus on adults and their care, and that's clearly very important. But what we wouldn't want to do is to miss the focus on children and young people, and obviously particularly concerned about that in Newham, given the age of the population and the demographics here. But John, just be helpful to get some assurance that is being considered.
Well, I think for how we decide to do things in the borough, it's absolutely vital we carry on as we are. I see the focus from the provider collaboratives having very much on prevention as specialist work as well, and it's going to be interesting for them in how they connect into boroughs to support the public health work, the preventative work, as well as collaborate at scale on specialised. So that draw very much should be there. I think we'll have to see how the appointments go for the ICS board, but I think that's an absolute crucial part of what will become the integrated care partnership between local government and health, is to make sure those representations and principles are set out in how this is designed. Because I know the legislation has been sort of released at some pace, and we've had slightly less lead-in time than we normally do to big reorganisations. But I think those principles are absolutely crucial for that.
Thank you.
I can't see any more hands or questions. Okay. Thank you very much. Item 8. Leonardo.
Hello. Thank you, Chair. We'll just have a brief update on the Newham Safeguarding Adult Board Community Engagement Project, which I think we presented as one of our priorities back in March for the current year. The project is a collaboration with the Newham Safeguarding Adult Board, and it resulted from a feedback that we received showing a lack of understanding of safeguarding in the community, but also a lack of data not reflecting Newham's population. So Julie Powell, who's our Chief Executive, she made a presentation back in March at the Newham Safeguarding Board, where we made a proposal to address the concerns that we had. And this was around doing some community engagement with local vulnerable communities around safeguarding issues to improve their understanding of safeguarding in the community, ability for people to recognize safeguarding issues and how to report incidents. But also what we wanted to do was around obviously capturing people's views and experiences, but also understand from residents what they think that the SAB's priority should be going forward. Working with the SAB board, we want to use this information to inform the board in the development of the next 3 years strategy, but also to ensure that there is a clear focus on prevention and early intervention going forward. So as part of the proposal, what we have done over the past couple of months has been setting up a task and finish group with terms of reference, and the task group has been set up, the membership has been identified by the Safeguarding Adult Board's business manager, Anne Ibezi, who's working with us on this project. The partnership includes care homes, the fire brigade, LBN, domiciliary care commissioning, Carers First, and a number of local charities, including charities that work with Somali communities and other Asian communities. We also recruited local residents. At the moment, there are 3 part of the Task and Finish group who are also part of the London Safeguarding Board, and they came on board as because they have lived experience of safeguarding, so as expert by experience. Now, over the past few months, due to COVID, we have done quite a good amount of engagement in the community, but because of COVID, we had to adopt a variety of tools or techniques for that. So we've done a lot of surveys online, social media, through WhatsApp, through our volunteers to reach their communities, and more recently, a bit more of a face-to-face community engagement. So as I said, the engagement is 2 parts. One is about engaging and informing communities about safeguarding, and the other is about finding out what people's understanding of safeguarding and what should be done is. And 2 of the main questions that we asked residents were, one about what people feel that is an important aspect for adults at risk in the community, for them to keep safe at home and in the community. And the emphasis from the people that we spoke with was around knowledge of services and support available, removing language barriers, and this comes across not only under safeguarding, but comes up often in other pieces of research that we do, particularly around language barriers. Creating strong networks, both in terms of personal, professional, and in the community, and a better understanding around what the dangers are. I think a lot of people that we spoke to, people seem not to be aware of what the safeguarding principles are in general, but what constitutes a safeguarding. Some people act in a way that they think they're being helpful to someone, but actually in reality, it's a safeguarding case. And people also talked about promoting a dialogue between residents and professionals. People that have had experience of safeguarding feel that there's a lack of connection with services, with providers, and they kept referring to both health services, social care, and so on. The second question that we asked them was around what would help them improve, what they think that would help improve people's understanding and the support available. And there was a general consensus around delivery of awareness workshops and training. People talked about a lot of outreach work, referring to local markets, high streets, going to faith groups, schools and colleges to speak to people face to face. There was also feedback around people saying that it would be helpful to have a confidential helpline, easy to access. Now, Newham does have a helpline, a safeguarding helpline, but a lot of people didn't seem to be aware of it. And another thing that a lot of people have mentioned as well was around providing information in community languages through community groups. And there was an emphasis around working with community organizations. In terms of next steps, we will continue this engagement between now and the end of October. And then we will publish the findings of the research in a series of community safeguarding events in the National Safeguarding Week in November. Once that's available, we'll obviously present the full findings at the Safeguarding Adult Board, and of course at this board in the autumn as well. Thank you.
Thanks, Leonardo. Any comments or questions for Leonardo?
Thank you, Chair, and thank you, Leonardo. Just a very quick question, and maybe this will come through in the final report, but in terms of that first question, and I think, from what you were saying, there was a question about reach in terms of safeguarding and the modes of communication in terms of getting information out. As part of the questioning that you did you collect any quality information about what those channels could be? Because I know you mentioned about, you know, the professional networks and, you know, the support services, but was there anything that was picked up as part of that survey where, you know, what residents would actually like in terms of getting that reach out there?
Yes, there's a bit more detail. I just give you have given an overview of what we've done so far. But yes, there is some detail in terms of how people want that information to go out, and in terms of channels and formats and so on. So we have a little bit more detail on that. Yes.
Excellent. Thanks, Leonardo.
Any other questions or comments for Leonardo?
Oh, thank you. Well done.
Are we due an annual safeguarding report?
It was at the last meeting, Chair.
Achievements?
Both. Both the chairs came to the last.
Yeah, and we asked for them.
Sorry?
Was it 6 months following, or was it a year?
Yeah. Annually, yeah.
It's annually.
Thank you, Leonardo.
Thank you.
Sorry, I can't see. Homelessness and rough sleeping pathway. I can see Carl and Simon.
Yeah, there's Carl.
Hi everyone, I'm very dark. I think that's because it's late. I think we might be starting and then moving on to Canada and Emma. We've been asked to come and give an update on the rough sleeping work that we've done to date. What we have tried to do, just in terms of kind of trying to be effective time-wise, is shorten down our draft a little. We could talk for hours pretty much about rough sleeping, but we really want to bring in a kind of rough sleeper voice to the meeting. So we'll play a short kind of film just highlighting someone's success. Yeah, the slides are slightly different from the pack. I will share my screen. Right, there you go, Carl.
Thank you very much, Simon. So, as Simon says, we're gonna kick off by talking about the rough sleeping pathway before we move on to listening about service users' own experience, and then Candida and Emma are going to talk about the draft rough sleeping and homeless strategy. But as you can see from the slide that's on there at the moment, in terms of setting the scene, we know that we've come a long way. I think everybody in this meeting today appreciates, just how far we've come, and the supporting the rough sleeping issue in Newham, and some of the headlines on the slide illustrate that perfectly. And we can talk about the successes as much as we want to, but we know that there's still a lot to do. But before we sort of get into that and get into what the challenges are, just want to kind of briefly cover what we think are the most unique and new elements of the approach that we've taken over the last year or two. I mean, the headlines speak for themselves, and we know that we had over 100 people, living on the street in Newham, nearly 2 years ago. The last formal street count, there was 11 people on the street, and that speaks for itself. And we can also say that, in March 2020, since March 2020, we've supported over 650 rough sleepers at that time. And I think what the three most key characteristics or elements of what we've been doing are firstly, the intelligence-led approach. So we talked, whenever we get the opportunity, talk about our vision about, a rough sleeper isn't just a rough sleeper. That's not what makes them. It's not because they haven't got a roof. They're usually an individual with lots of complex issues that have all come together so that they end up living on the street. And that is what we've really got to understand. So unless we understand their particular journey and what they want, what their outcomes are, then we're never going to be able to support people effectively. We do that across adult social care, but we wasn't doing that effectively with rough sleepers. So we're doing that now, and we have a system in place to do that. We've also really, we think, improved our outcomes by speaking to people who need the services. A good example of that is how we listen to people and how we actually used people in commissioning our new integrated rough sleeping service. We didn't just bring them in for part of it. We actually gave a part of the evaluation and the method statement and asked them to look at what was important for themselves. And I think the other thing that's really important to say is that with supporting people with a rough sleeping history, it's about the long term. So just putting a roof over somebody's head is not going to solve the problem. We have to work people to give them the skills, the tools to be as sustainable and as independent as possible. So just very quickly moving on to what the real sort of key challenges are in rough sleeping. So I've sort of mentioned in 2019, we had the second highest street count, and that actually increased by 135% since 2015, 2016. So again, coming down to 11 people on the street is a success, but we know it's fragile, so we have to get the infrastructure in. Everybody knows what a unique position we're in with Stratford Mall, and being able to close that at night has massively supported our efforts to end rough sleeping. We know that it drew people from not just parts of London, but all around Europe. And there are lots of different issues that we haven't got time to go into today. The resources and the infrastructure that we had in Newham were nowhere near comparable to other boroughs. And we're building them, but we're building them slowly because it's very difficult when you think about the number of hostels that we have in neighbouring boroughs. We had nothing like that. So when COVID-19 hit, there wasn't an easy solution. We couldn't turn other old hostels like other boroughs did into new ones. So we had to work very quickly and very flexibly. And I think we've done that. So I'm aware of time too, so I'll hand over to you, Simon.
Thank you. There are a number of slides in your pack that really refer to the detail. We'll kind of skip over some of that because you can see the milestones and the various things that we've achieved and how we've done it. I'll just go straight to the outcomes. And I was here for the item on data, just kind of listening in. I think one of the things that has been a hallmark of what we've done in the council, but with health colleagues, is really harness the power of data alongside lived experience to inform our intelligence approach. Without that, we wouldn't have achieved these outcomes because we wouldn't have developed pathways to meet those needs. We've supported 650 rough sleepers over the last year. 205 have been supported to regularise their immigration, with 91 achieving a positive outcome so far. 96% of rough sleepers are now registered with a GP. That was well below 20% when we started that. 60% of rough sleepers have received a vaccine. 15 have found work. 84 are currently engaged in substance misuse services. And I think the important figure to really focus in on is that 94% of those we have supported haven't ended up back on the streets. And I think that's a testament to our longer term planning. And all of that is then summarized in this kind of graph. You don't go from 105 to 11 without kind of detailed work with partners across health and care to achieve things on an individual level. So we won't kind of talk through some of the sustainability stuff, but we will talk about kind of our priorities. Carl, do you want to do the first slide?
Yeah, sure. Thanks, Simon. So I just touched on the integrated rough sleeping service. So what we've managed to do this year is, for the first time in a long time in history, to commission a fully integrated rough sleeping services. One of the issues that we inherited was there was a number of kind of disparate support services. Again, not many compared to other local boroughs and comparable boroughs. But what we've been able to do is develop a a tender where we brought together the different services into work packages, so we could look at bringing in one particular provider that would lead a number of consortia, as it says on the slide, and that one actually went live in September. So we're in the mobilization phase now, and it's going well. The other thing that we're really excited about, which Cabinet has given us approval to actually purchase a property which we will develop into a Centre of Excellence Assessment Centre, which will create a kind of pathway within a service for people who can come straight off the street and then be supported to move into sustainable accommodation at the speed and the pace that's right for them. It will need major work, and we're working to design that service now, and it's scheduled to launch in 22-23. That will obviously be led by the successful consortia that won the integrated rough sleeping service. And then, of course, we can't not speak about Stratford Mall. We have been able to secure the nighttime closure, which is pivotal to our rough sleeping offer. If it was to open again, we are certain that it would attract rough sleepers. So we are working hard with legal colleagues and other colleagues across the whole of the council to identify a long-term option to keep it closed during the night. So they're the key issues for us, the key priorities. Thank you.
We'll talk about the strategy in a second, but the final thing that we're trying to do this year is that the council led a bid for kind of hospital discharge funds for rough sleeping and homeless. And we were successful in being awarded 1.1 million. What that's going to do is kind of three specific things. We're going to have a team that will support people through the integrated discharge hub who are rough sleepers or homeless to address their needs appropriately, so they're not rushed through the system and we get readmission on the other side. So it's a real key priority that we support people appropriately and sustain their improvements. The second part is we will have a step down unit where people can move out of hospital, have some time to kind of stabilize themselves, whilst we also support them to find their next steps. So again, they're not discharged to the street. They will be supported in the way we support everybody else. And we will find appropriate next steps within 4 to 6 weeks. And the final bit is that our success collectively has been about wrapping services around individuals during COVID with extra money. Now, these services can be wrapped around individuals with a bit more creative thinking and less money. So we're going to look to work collaboratively to work out how to do that. But instead of us kind of waffling on for hours, I think it's way more poignant to kind of hear from a rough sleeper. So I'm going to share a story now.
At the age of 33, I ended up losing my home, marriage and my life. I ended up in prison and turned drugs in prison. That's took me on nearly 20 years of homelessness, inactive drugs, crime, petty crime. And I've done that since the start of the pandemic. When the pandemic started, authorised payments and emergency clearance of the streets, which Thames Reach, the outreach team, were charged to take everyone off and put me in safe accommodation, and I got safe, and they've done it absolutely brilliantly. CGL, a local drug agency, stepped up and got rid of us to be in a better borough during COVID. They've opened up, helped people open up food banks in all different parts of the area, supported them. They've completely cleared the streets of anyone homeless that was willing to engage with them. A number of people like myself were clean and sober because of the support they've had. I've gone from behind here a couple of years ago, and all the tents that used to be lined up there. I've gone from there into a room, engaged in there. I've gone from there, I've been offered supported housing where I live now. In there, I've got staff if I want to engage, and if I don't, they want to know why I am. So, yeah, it's the pandemic, as much as it's horrific for a lot of people, it's also given a lot of people in the homeless addiction community in the borough of the chance to change. All the services are there, all the services stepped up, the funding's there, and then anyone don't step up to take this opportunity, they're going to be ready for years. I've waited 15 years in Stratford for something like this to address the homeless and addiction community needs. The major thing COVID has done for me is to give me the opportunity to engage with the council that stopped me going to prison for the last 2 years and completely changed my work. The whole body steps up, all the services, food banks, councils, outreach teams, for local drug stations. And I'd like to say thank you from the bottom of my heart, not just for me, but for a lot of people that are like to change for the better.
Thanks all. It's a little rustic at the moment. We only did that on Friday, so we're still editing it to a better and a standard. Over to Candida.
Sorry, did you just pass over to me, Simon? I'm having a bit of a time lag. So excuse me if something happens while I try to do this, because my connectivity has gone a bit funny on me. So okay, I'm just going to share some slides to give you an overview of the homelessness and rough sleeping strategy. You'll see that? Yeah, hope so. So basically, it's just to bring this to you because we're out to consultation with our homelessness and rough sleeping strategy. We have one in place at the moment, which was a 2-year strategy, and it was an interim strategy. And that one, for reasons that we've just covered, is very sort of focused on rough sleeping. But rough sleeping is one aspect of homelessness, and there's much wider sort of homelessness issues that we need to address in more detail. And we've done that, we hope, with this new strategy. And what we've also tried to do is make it more of a kind of council-wide document, because homelessness is something that is the responsibility of services across the council and helping to prevent homelessness. And obviously it has a lot of implications, homelessness for health and well-being, children's development, etc. So we've tried to tie it in as well with other strategies, for example, the health and well-being, the 50 SEP strategy, which has a particular bit about temporary accommodation overcrowding in there, so that all the strategies kind of read across. So basically the strategy is boiled down to sort of 6 key objectives, and that's kind of organised into chapters, and under those are all the kind of work streams that we want to follow, or we are following, to reach those objectives. So I'm aware of time, so I'll kind of skip through just to give you a flavour of what those objectives are. So the first one's understanding current and future needs, and this is all about using our data to drive continuous improvement. And there's already been sort of conversation about that earlier in this meeting, and this is something that obviously Simon and Carl have had a lot of success with their minimum data set that they've established, and we want to do that in a wider scale by using, for example, the information that we have available to us from our private rented sector licensing schemes and the general homelessness data we
We're losing you, Candida.
Engaging with landlords and private rented sector tenants.
Simon and Carlin.
Yeah. So if you could hear us, if you switch off your video.
Sorry. I'm getting messages.
There's a officer colleague called Emma, who, if Candida is still having some problems, can maybe pick up, or I can talk through aspects of this because I'm the portfolio lead at the council.
Yeah,
whatever, if Emma wants
Emma,
to.
are you?
Can you hear me now?
Oh, great. Yeah. Oh, I think she's... Candida, are you there?
I think she might have just dropped off. I'm not 100% sure I can share my screen, but I will give it a go.
Yeah.
Thanks, Emma.
Is that coming up okay?
Yeah.
Yeah. Do you want to pick up where she left off, and then when she comes in, swap over if that works?
Yeah, that's fine. So I think Candida's mainly covered off this first point. The kind of key thing to note is that it's really about data, and it's about making best use of the data we have, and also sharing data through the kind of H-click data return. Then the next section is on preventing homelessness through early help. So stopping people becoming homeless before they get to the point of presenting to us as homeless. And a lot of that is about the private renter sector. Obviously sort of at the more extreme end, tackling harassment and illegal evictions, but at the sort of more sort of earlier level is really about communicating and engaging with private rented sector tenants. And there's a piece of work ongoing at the moment with Generation Rent, looking at how we do that better. It also involves working with landlords to just really try and tackle the stream of people that come in from the private rented sector. It's also about financial insecurity and debt. So again, all of these kind of themes are about nipping things in the bud. And so the Tenancy Sustainment Hub, which is that penultimate point there, will be co-located with our newer money to just really try and bring all of those things into one place. And the final point about enabling survivors of domestic violence to stay in their own homes, the kind of key action coming out of that would be establishing a sanctuary scheme, which means that people won't have to then move out of their own homes. Their home will be made safe for them to continue to live in. So this one I might pass over to Carl and Simon, if that's okay, if that's not too many cooks.
You can probably... Emma, I'm back on if you want to...
you're back.
To me. I'm sorry about that, everyone. Completely just went cut off on me. Okay, so supporting people to move off and stay off the streets. I don't think we need to sort of go through this in detail because this is just being covered. But obviously the 5-year strategy is building on the work that's already been done. And concentrating on kind of expanding that. Can you move to the next slide, please, Emma? As soon as I'm sharing your... So improving access to better housing that meets the needs of residents is quite a big bit that takes in a lot of different aspects. So we're talking about here working in partnership to provide more sort of personalised support to people, improving communications, especially with households in temporary accommodation who tend to be forgotten somewhat, especially if they're out of borough. Again, maximising our opportunities in the private rented sector for preventing homelessness and also to get a supply of accommodation for people. We need to look at offering more kind of accessible accommodation and accommodation that meets people's sort of needs if they have disabilities. Ensuring good standards of temporary accommodation, of course. A lot of this is about our standards and participating in kind of London-wide schemes, such as setting the standards to make sure that the temporary accommodation we're using is of decent quality, and driving those standards up, and also making use of empty homes and council voids where it's appropriate. And we've just set up an empty properties team, and we're going through kind of looking at our empty properties at the moment. Next slide, please, Emma. So a big one is reducing the use of temporary accommodation. We have over 5,500 households in temporary accommodation, and particularly a work stream about reducing nightly booked accommodation, which is more expensive and more unstable because it's booked on a night-by-night basis, and it's not protected through tenancies. Looking at getting more supply of sustainable and affordable accommodation, and just developing a more an improved move-on offer to temporary accommodation residents, and that is to give more support to people who are in temporary accommodation who could be there for years to move on to alternative accommodation, and to sort of help them move through that process. So the last one is adopting a partnership approach to preventing homelessness and improving well-being. So we're doing a number of kind of different work streams and working jointly across services. So to support adults with social care and mental health needs. We've also got a lot of work streams going on with children and young people around young people's pathways, care leavers, serious youth violence. And we're doing a lot to, and Simon mentioned this as well before, to work across services to maximise grant opportunities. So for example, we've got a mental health hospital discharge pilot that we're doing. There's the scheme that Simon was mentioning with the North East London one. And also we've just got grant money for ex-offenders and working with ex-offenders around their homelessness as well. Working with faith groups and community partners is something that we want to sort of improve and increase. And we want to do a lot of work around supporting survivors of domestic violence, including getting accreditation for DAHA, which is best practice. And we also, Simon and Carl mentioned, working more with service users and people with lived experience of homelessness. So can you just go to slide 10, Emma, please? Thanks. This is just to show you kind of, alongside the homelessness strategy, we have to publish a 12-month action plan, and we have to review that at the end of 12 months. So this is kind of what the action plan looks like, and it's the detailed sort of things that sit beneath those overarching objectives, and it shows kind of who is responsible for that. And you'll see here that it's not just housing or adult, you know, there's a number of services who are kind of signed up to be responsible to meet these aims. And the full kind of draft action plan is in the pack, as well as the draft strategy. So we would just like to ask that I think the consultation ends on the 23rd, is it? Or 24th of September. So we'd really like to get any comments and feedback, and also if there are any sort of colleagues or people that you want to share it with who you think could give us feedback that we could take into account, we'd appreciate it. Thank you. I'm sorry for galloping through that.
Do we need to do standing orders?
Yeah, if we could move for
15 minutes.
15 minutes.
15 minutes, yeah.
Okay.
Thank you very much, team. If I could, Andrew.
It's really great projects, and it's going to be a game changer for us. And fantastic to hear. I don't think I missed it, and I'm really sorry if I did. I wonder, are there arrangements for, or opportunities perhaps, to manage long-term conditions as a consequence of this? And also, how do we maximise the interaction at the front door of the hospital? Is that the same as the discharge team, or would that be a different function?
Part of the grant we were successful in kind of getting for the out-of-hospital work allows us to bring in some coordination capacity. I think that's really key in terms of mapping out who's using what for what. A bit like we've done with the rest of the rough sleeping stuff, and then targeting specifically. Like we have primary care nurses, Wax knows this, he works with them, who kind of support rough sleepers. But can we do more? Should we do more? And I think the intelligence we gain through the pilot will definitely inform what our service pathways look like more on the health side than the local authority kind of over the next year. I think the pilot's really important.
And just quickly before I make or ask a question, on the conditions point that you raised, that's been addressed twofold. One, looking at ways in which we can strengthen our private landlord licensing scheme response and regime, and how we hold private landlords to account, because the condition of quite a lot of the housing cases that we get as a council are absolutely appalling. And we're working, as mentioned during the presentation, with Generation Rent on a pilot that involves 3 other local authorities, and Generation Rent is one of the UK's most significant tenant right organisations, and we have actually established a tenants' rights unit to highlight and inform our residents, 68% of whom live in the private rented sector here in Newham, of their rights, and knowing that they've got an advocacy friend here in the council, but that will need to be also I guess socialised amongst the partnership network, so that they can sort of route people to that service provision. And like one of the issues that we're going to need to be mindful of, and this is a point that came up in discussions that I had with councillors on Monday about the private landlord licensing enhancement features, including the Generation Rent. How do we manage institutionally, in the context of, say, 68% of our resident population living in the private rented sector, an enhancement of their knowledge of their rights, and then the pressure that that places on the council as an institution to respond. So we're not, we're remaining agile and responsive. So I think that's something that we've got to work through. And then conversely, we've allocated, as part of an ambitious programme of refurbishment across our entire 60,000 unit council stock, both in terms of enabling people to downsize when they've outgrown their large properties to free them up for larger families, and then moving them on to nice units, either in our new developments or elsewhere in the borough, but also making sure the conditions are really really well as well. So I wanted to just add that. And there was something else I was just going to say in relation to the penultimate slide that was presented by Candida, the importance of the partnership approach. And I don't know how many of the members of this board that were there at the time will recall, in the first year of the Health and Wellbeing Board convening under this administration, and Wax, you'll remember when we had the brainstorming sessions and we placed homelessness and housing as alongside youth safety and poverty, our top 3 priorities of strategic intent. So I think this will go a significant way in enabling us to respond to that, and really to manage expectations as well. It'd be remiss for me not to say the following. We're coming at this after literally decades of ill thought through thinking around how to coherently and in a systems wide response way deal with issues of rough sleeping and homelessness. And it's a huge, massive endeavour, and it sits within the framework of a 5-year housing delivery strategy that we've also published and approved, I think. Yeah, we have. There's so much going through. It's hard to keep track, but I wanted to commend the team as well, because it's been really, really amazing work. So well done.
Any other comments?
Just a comment, really, just to thank Officer. I mean, this has been a remarkable journey. You know, we moved from 50 down to a single figure, and we got intelligence-led pathway. We're looking at the health aspects. 96% of people are now GP registered, so massive achievement. And working together with Housing Service in developing the latest strategy, which was approved by Cabinet recently, great achievement. And I look forward to obviously the action plan, which has been part of the process, to make sure we sustain that progress we've made tremendously. And this is the flagship service, Chair. Actually, it's been nationally recognized by many other authorities that are following what Newham is doing. So well done to officers. Thank you very much indeed.
Brilliant. Item 10. Well.
I think, so here's my suggestion. I mean, we know we've got a challenge with oral health. We know, but what we don't have in the room is the commissioner of our dental services. I know that commissioner has been lined up to come to the next meeting. What I think would be really good is if we can soon, over the next couple of weeks, pull together a set of questions that we have for the Dental Services Commissioner. We'll also bring back stuff on the recovery of the prevention offer as well, because I think it is absolutely critical that we don't see dental treatment as the panacea here. Definitely don't see surgery as the panacea. So we need to do the prevention piece, but I think it is absolutely critical that we get the right questions. We don't wait a couple of months for the Commissioner to come, and then we've got loads of questions then that we get those questions in advance and then can have a session. I also wonder, given the long-standing concern around this issue, whether there is someone from a local dental committee who could be part of the conversation, and we could invite a couple of other people to the session for a bit of a more, so we have the right expertise in the room to ask some questions.
Thank you, Chair. I think Jason has summed it up very well, Chair. And in fact, I had a meeting earlier on, John, myself, and Health Watch in terms of the work the Health Watch has done in this regard, and there are serious shortcomings. And as part of the discussion, some of the actions we agreed today were to look at the baseline figures. What is it that we currently have in terms of the services new, bearing in mind our demographic, the transient population, the poverty level, etc. And I really am grateful to Health Watch for their background information, and we will be together with John and the Commission to use some baseline figures. And I think the very big issue is that the formula using to allocate the dental support in is adequate, but frankly, from practical purposes, that isn't the case. That's something I'm really pleased that this is coming back here, and we can either look at what we can do from a well-being point of view to put pressure on England to make sure that our allocation is reflective of the local need, which currently it doesn't. That certainly seems to be the evidence so far.
Can we make that case before they come?
I think we can, and we discussed it the last time, and there's the clear issue when they came to the last board that we have a huge undersupply of dental appointments.
Yeah, so the UDA capacity is less.
Yes. So that will be part of the questions.
Any update on who's going to be the commissioner going forward? Do you know?
So I think this continues to be NHS England.
Yeah.
However, I don't know whether they have the ability to delegate it down to ICS. But I think Councillor Ali makes a good point. We want to make sure we really understand what has been commissioned, what the uptake is, what the number of dentists are available, so we have a very informed understanding of where we are in comparison to others and how well people take up that. We are informed in developing those questions for that debate.
The uptake of paint.
Sorry?
The uptake of that varnish.
So that was all obviously suspended during COVID. Yeah. So we need to get an update from that prevention service. Yeah.
Especially
that will be one of the reasons why there's an uptick in children with issues.
That's what,
because it's very effective.
Yeah. If I may, also, I mean, the process that's been suggested, I really very much welcome that, because when I was going through the Integrated Care Board piece, I noted that the ICBs will also be responsible for commissioning a range of functions that also cover dental services other than primary dental services. So there will be oversight under the auspices of the Integrated Care Board. And I guess it goes back to one of my earlier comments on that agenda item. How do we ensure the maintenance of proportionality and equity when things are so acute here? And then the other thing that I just wanted to say, just so it's noted for record, Dr. Rima Vade had sent myself and Wax an email, and I just really wanted to read out because it very much evokes with devastating impact the situation the colleagues such as her are facing on the front line. And so she talks how at a previous HWBB meeting, we had a presentation from the Dental Commissioning Board outlining the dental service within the borough. We are currently seeing a higher number of emergency dental presentation in primary care, either direct or indirect via 111. Patients have told me they are unable to receive NHS treatment or are being told they need to pay private fees to receive treatment. Many are told the dental practice has very limited no NHS access. This creates further inequality in the borough. Primary care is already under great pressure, and it will be helpful to get an in-depth understanding of how the dental practices in Newham are operating. And then goes on to ask if something could be brought back to the following Wellbeing Board and Health Watch previously presented data on dental services, and it may be worthwhile asking to see if they plan to do any more audits, update, and our preparation for when this person comes.
If I may, Jill, I think the piece of work that I mentioned earlier is precisely going to do that, to give us some basic facts and figures to see what exactly is happening. And that is, Rima is absolutely right, that if patient rings a dentist, they say, well, we don't have any NHS appointment. However, if you want to come in as a private, then you come in straight away or whatever. So yeah, those are the issues being looked at, and perhaps it will inform further discussion at this board as well. So.
Okay. Any other business? 17th of November, next meeting?
Yeah.
Yeah, so we've got some items.
Yeah.
Penciled in.